Hello, good morning everyone. Chalo. So welcome to the FMG one shot session. Basically, I'll try to compress the 3 days of 2.5 to 3 days of pediatrics into 3 hours of the most important, most high yield stuff. What I'll basically start with is I'll start with I'll talk about some important previous year questions of FMG and also NEET PG, because we have seen that in the past 2-3 sessions, in the past 2-3 exam, FMG is actually repeating questions from NEET PG also, and sometimes even INI-CT, but INI-CT I feel is a slightly higher level and it's not required for your point. 3 days of 2.5 to 3 days of pediatrics. So INI-CT is essentially not required. Is not required in your particular case. So first, it will be a sort of a mixed bag. First, there will be sort of a test and discussion, but also a revision of the most high yield and the most important topics as far as pediatrics is concerned. I'll try to complete it within 2.5 to 3 hours, 2 to 3 hours between that will be the duration. And then if time permits, I'll try to do a rapid revision also of important images that I've kept for later. But if we don't have time, we can forego that. But this is the most important, most high yield thing. As I've always said in my videos, that what's most important is the first read. Yes, you have to understand the topics also, but unless you revise them, and most importantly, if you don't revise them in the last 7 to 10 days, the things won't be on your surface. And if they are not on your surface, you won't be able to mark the correct answer in your exam. You will know that, okay, this is an easy question, but you will get confused and you'll make a silly mistake. And that is the reason why last 7 to 10 day revision is important, irrespective of be it NEET PG, FMG or INI-CT for that matter of fact. So your exam is still more than 1 week away. Use these sessions, these one-shot sessions, to concise your notes, to understand the high yield topics and revise these high yield topics in the last 1 week. And I can guarantee you what is 150, you will definitely get 200, more than 200, right? Ab ki baar 200 par. With that, let's begin our session with some let's begin. Yes, if someone is asking, can this be useful for NEET PG aspirants? Definitely, you can watch it. Basically, what's going to, if you have not done pediatrics at all and you don't know how to revise pediatrics, definitely watch it. My level is going to be between NEET PG and FMG, not completely NEET PG, not completely FMGs, but it will definitely, since it's a 2.5 hour session, it's definitely going to help you even in NEET PG. At least the easy and the moderate questions are getting solved. If not the tough questions, at least if you are totally zero in NEET PG, then I will say that definitely watch this session also, because at least the easy and the moderate level questions will get solved, maybe not the tough levels, because obviously there is some amount of difference between the level of FMG and NEET PG. So, but still FMG over a period of time has become a tough exam. It's not like it has remained a very easy exam. It has become slightly twisted. It has become slightly more clinical. That will be reflected in the questions also. So even if you're a NEET PG and you're like, sir, meko bilkul hi nahi aati pediatrics, I want to, this is the only thing I'm going to watch before the exam, then do it. If you already have notes, you have already made some concise notes, or you have already done some revision, then preferably go back to that instead of listening to a new person. Even though I know I will teach you well, but still better to revise. So I hope you have understood. I hope you have understood who even the NEET PG aspirants who probably might benefit from this FMG revision session. All right. So first, motivation quote that what's more important is that you try. Michael Jordan himself said this was written in my Robbins also, right? That he has taken 9,000 shots in his careers and has missed multiple times, lost more than 300 games. But because he has failed, that's why he keeps on winning. Because he keeps on trying, that's why he keeps on winning. All right. So don't lose hope and keep on working hard and keep on giving your best shot forward. And if you take my example also, I got depression. I was in depression. I had 2 months. I was admitted for 1 week in the psychiatry ward. I came back from that. My rank was around 2000 in the November session, and I prepared for barely 4 months after that. But from 2000, I got to a 17th rank. So it's fully possible. Abhi bhi tumhare paas you have more than 3. Well, NEET PG aspirants have 1 week, but FMG aspirants you have more than 3 weeks. Do the best possible revision, and even if you feel that you're lagging, you're at that 130, 140 mark, I'm pretty sure you'll get into the 150, 160 zone very easily. Those are getting 160, 170. Ensure that you don't fall below the 151. Ensure that the revision is proper so that you stick in the 160, 170 zone and maybe go beyond the 200 zone as well. All right. With that, let's start our session. I shall, I will. Just always keep on telling you that. Let's begin. Now, the first question, I'm not giving you any options. When is the height of a baby double that of birth? All right. This is a NEET PG, INI-CT and FMG. All three have asked it at some point on time. So it's that important a question. All right. So the question is asking, when is the height of a baby or a new child double that of birth? So we have to understand that at birth, the height is 50 centimeter. When is the height 100 centimeter? When is the height 100 centimeter in case of a person? The answer is 4 years. The answer is 4 years. All right, and I'll talk about just wait for a moment. I'll talk about how the height increases. And when is the height of a child half that of adult height? Half that of adult height. So what is the adult height? We can take adult height to be approximately 170 centimeter, 160 to 170 centimeter. We can take it to be 160 to 170 centimeter. So half is around 85 centimeter. Half is around 85 centimeter. So 85 centimeter height. A child reaches 85 centimeter height at approximately 2 years of age. At approximately 2 years of age. These are two radically different questions, but people can get confused. One question is asking, when does your height double as compared to your birth? That is 4 years. Another is asking, when is your height half of adult height? My height is 165 centimeter. I'm an adult. 82 centimeter, 85 centimeter. When is that height? It is approximately at 2 years. The more appropriate answer will be 18 months to 24 months. The more appropriate answer is going to be 18 to 24 months. Now let's discuss how does normal weight progression, normal growth of weight, normal growth of length, and normal growth of head circumference occurs as far as a normal baby is concerned. All right, and then we can see how questions are getting framed from this and how that particular table. That's a table that you will keep on forgetting, and that's why I've kept it very first in the very first part of this revision series. And those numbers, it's very easy to forget numbers, and that's why it's very important to keep on revising these numbers again and again. All right, so let's begin. At birth, the weight of a newborn is 3 kgs. The normal weight of a newborn is 3 kgs. At 5 months, the weight doubles. It becomes 2x. It becomes 2x. So it becomes 6 kg. At 1 year, it triples. It triples. The weight becomes triple the birth weight. So it will become 9 kg. At 2 years of age, it becomes 4 times. It becomes 4x. So it will be 12 kg. At 3 years of age, it again gains 3 kgs. It becomes 5x. It becomes 5x. So now it will be 15 kg. But at 5 years, now the growth is starting to slow down a little bit. All right. At 5 years, what will happen? Now in 2 years, the baby is going to gain 3 kg. So at 5 years, the weight is going to become 6x of the birth weight. 6x of this is x, this is the birth weight. And now the birth weight is going to become 18 kg. Now the weight of the baby is going to become 18 kg, which is 6 times the birth weight. And at 7 years, it is 7x the birth weight. It is 7x the birth weight, that is 21 kg. So you can see initially the weight increases very rapidly. At birth, it is 3 kg, it doubles, gains 3 kg only in 5 months, then gains another 3 kg in another 6-7 months, and by 1 year, you are 3 times the birth weight. So weight is increasing very rapidly. It increases very rapidly till 1 year of age, then it starts to slow down. Then in next 1 year, only 3 kg, 12 kg. Then in next year, only 3 kg, becomes 5x, 15 kg, so on and so forth. But now let's come to what is the length. You will see that length increases much lower as compared to that of weight. At birth, the length of the baby is 50 centimeter. In 1 year, he gains 25 centimeter. In 1 year, the baby is going to gain 25 centimeter and it is going to become, baby is going to become 75 centimeter. At 2 years, he's going to gain, so he gains 25 centimeter. At 2 years of age, he's going to gain half of that. So he's only going to gain 12.5 centimeter. So the height is going to be 87 to 88 centimeter. 87 to 88 centimeter. And then finally at 4 years, the height becomes 100 centimeter. The height becomes 100 centimeter. So can you see the difference? It's a very important difference that I want to talk about. Birth doubles, becomes 2x. Birth weight, the weight doubles at 5 months only. While if you take the length and the height of the newborn, at birth it is 50 centimeter and it becomes 100, that is 2x at 4 years. At what time? 4 years. So weight doubles in 5 months, length or height doubles in 4 years. All right. And beyond 4 years, the baby grows at a rate of 6 centimeter per year till the baby reaches puberty, till the person reaches puberty. When in females, they grow at 8 to 9 centimeter per year and males grow at 9 to 11 centimeter per year. Males grow at 9 to 11 centimeter per year. In puberty, now the rate of height increase and length increases more. Females, obviously we know that girls are shorter than males, right? So girls, their growth is around 8 to 9 centimeter per year, and in males the growth is around 9 to 11 centimeter per year. But this is the most important differences I wanted to talk about, which has been asked. Length doubles at 4 years, weight doubles at 5 months itself, all right? And half the adult height, so half the adult height is 85 centimeter. At 2 years, you are 87 centimeter. So slightly less as than 2 years. That is why the better answer is going to be 18 to 24 months. All right. Between 18 to 24 months, you will be half of adult height. You will be half of adult height. All right. So I hope everyone has understood. All right. Now let's look at her head circumference. As far as head circumference is concerned, when a baby is born, the head circumference is around 33 to 34 centimeter. At birth, the head circumference is around 33 to 34 centimeter. This is the birth head circumference. In the first 3 months, the baby gains head circumference at 2 centimeter per month. 2 centimeter per month for the first 3 months. Then from the 4th month to the 6th month, the baby is going to grow, the head circumference is going to grow at 1 centimeter per month. It's going to grow at 1 centimeter per month. And in the next 6 months, it's going to grow at only 0.5 centimeter per month. Only 0.5 centimeter per month. All right. So let's see what will be the head circumference. What will be the head circumference at 1 year? What will be the head circumference at 1 year? So initially it was 34 centimeter. In the first 3 months, it's going to gain 2 centimeter per month. 2 into 3. So it is 6 centimeter. In the next 3 months, 1 centimeter per month. So another 3 centimeter. So another 3 centimeter. And in the next 6 months, only 0.5. So 6 into 0.5 is 3 centimeters. And next 6 months is gaining only 3 centimeter of head circumference. So another 3 centimeter. So head circumference at the end of 1 year is approximately 46 centimeter. It is 46 centimeter. At the end of 1 year, it is 46 centimeter. At the end of 2 years, it is 48 centimeter, which is 90% of entire growth. 90. And this is again a very important question. This question in fact was asked, I always keep on telling, this question was asked in the IAP pediatrics quiz that I gave when I was doing my UG. So examiners love asking this question, that 90% of the brain growth or the head circumference growth occurs by what age? It occurs by 2 years of age. And at 2 years, the head circumference is 48 centimeter. The adult head circumference is around 53 to 55 centimeter. So 90% of that 48-49 centimeter already done by 2 years of age. 90% of the brain growth occurs by 2 years of age. All right, it occurs by 2 years of age. 90% of brain growth and 90% of head circumference at 2 years of age. All right, and you can always say, there is another important fact that I want to tell as far as weight is concerned, that newborn, I told you that the birth weight is what? Birth weight is 3 kg. I told you that the birth weight is 3 kg. It is called a low birth weight baby if the birth weight is less than 2.5 kg. All right, it's called a low birth weight baby if the birth weight is less than 2.5 kg. Now, important fact about birth weight of a baby is that there is something called as physiological weight loss. There is something called as physiological weight loss. And this physiological weight loss in a term baby is approximately 10%. T for term, T for 10, 10% in term baby. And they regain this by day 10 of life. All right, they regain it by day 10 of life. Regain, I mean that initially the baby is going to lose 10% of weight and it will become birth weight again by day 10 of life. So it is going to be, graph is going to be like this. It's going to be something like this, that on day 10, they again would have reached the birth weight. All right. So the nadir, where it is actually the lowest, occurs at around day 3, day 5. That has not been asked ever. What you need to remember is these 3 facts. In a term baby loses 10% of birth weight and regains it by day 10. Now, let's see another thing. Preterm baby loses 15% of birth weight, regains it by day 15 of life. Okay, easy to remember. Term baby, T for term, loses 10% birth weight, regains by day 10 of life. Preterm baby loses 15% birth weight, regains it by day 15 of life, or basically second week of life, by second week of life. All right. Very important small fact, can be asked. NEET PG definitely has asked and can be asked in your FMG exam also. So just wanting to tell you. Term 10% weight loss day 10. Preterm 15% weight loss, regain by day 15 of life. All right. So these are some important facts as far as your head circumference, weight, length and height is concerned. Now I want you to understand what is the difference between length and height. I have used these terms still now interchangeably, but they are radically different. Length means when you're lying supine. When you're lying supine. Height is when the baby is able to stand. When the baby is able to stand. Which is the reason we take a height when the age of the baby is more than 2 years. Because by 2 years, most babies will be able to stand properly, right? So there is something called standing height and supine length. When you're lying down, then you take length. When you're standing, that's when you take the height. And they are measured with different instruments, which I have shown you here. This length is measured with an instrument called as infantometer. This instrument is called as infantometer. While the height is taken by an instrument, I told you, you are taking height when you are standing. Stand, stadiometer. Stadiometer. All right. And obviously, like I said, length is taken during the first 2 years of life. The first year of life is called infancy. So the name of the instrument is going to be infantometer. So first 2 years, when you're taking the height, when you're taking the length in a supine manner, infantometer. When the baby is standing, stadiometer. For taking the standing height beyond 2 years of age. Beyond 2 years of age. All right. Now, let's discuss some important growth curves. These curves are called as Kaman's curves, and these growth curves are related to some tissues in the body. How some tissues grow. All right. I'm not going to tell you which tissue is what. You are going to tell me which tissue is what. The first tissue, the first one, this is A, let's assume. This I've already discussed. Which tissue is this? 90% of the growth of the tissue has already occurred by 2 years of age. 90% growth has already occurred by 2 years of age. Then there is a plateau. Which tissue is this? Which tissue is this? Can anyone tell me? 90% of the growth has already occurred by 2 years of age, and then there is approximately a sort of a plateau. Which tissue is this? Exactly, Mohan Priyanka is correct. This is basically the neural tissue or brain. So if they give you this curve, growth curve is related to which tissue? Brain. Now let's look at the second curve. This is essentially in a plateau. Basically, no growth is occurring till 10-11 years. And at 10-11 years, there is sudden growth. At 10-11 years, there is sudden growth. Which tissue is this? Which tissue doesn't do anything till 10-11 years of age, and when 10-11 years start, it suddenly starts to grow? Which tissue will be this B curve? Which tissue will be this B curve? Ridhima, yes. If you haven't revised pediatrics, then this is going to be helpful for NEET PG as well. So you can listen to the session. There's no harm in listening to a 2.5 to 3 hour session. You will only revise properly. Again, Priyanka is absolutely right. These are gonads. Excellent, Priyanka. These are gonads. Right? The gonads and the gonadal tissue are reproductive tissue. It basically lays quiescent till puberty. And when 10 years adolescent hits, it starts to grow. All right. So this is gonads. Now let's look at tissue C. Tissue C has a what is called as an S-shaped curve. S-shaped curve. It initially grows very fast. Initially it's growing very fast. Then there is a period of plateau. Then there is a small plateau. Not big, but slight plateau. And then again when the puberty is hitting, it is growing very fast again. So initially it is growing very fast till 2 to 3 years of age, 2 years of age, 2 to 3 years of age. Then there is a plateau, and then again growing very fast when you are reaching puberty, when you're reaching adolescence at 10 years of age. Which tissue is this? Which tissue is this? Can anyone tell me what is this C tissue? That initial 2 years you're growing very fast. That initial 2 years you're growing very fast, then you are plateauing, and then you're growing again very fast. Musculoskeletal, absolutely. This is the somatic tissue. This is the somatic tissue or the musculoskeletal tissue. Can you see, if I go back to here, in the first 2 years, there is rapid growth, be it the length or be it the weight. The first 2 years, you are growing very rapidly. Then it slows down. Only 3 kg weight gain increase, then only 6 centimeter height increase. Be it the musculoskeletal or basically the somatic tissue, there is going to be very slow growth beyond 2-3 years of age, and then it will again start at what time? It will again start at puberty. You will again gain weight again more at puberty. So this is a somatic tissue. The last curve is that the maximum growth is occurring between 4 to 8 years. Below 4 years, below 3 to 4 years, it is staying sort of quiescent, not growing that much. Beyond 8 years, it's also growing a little bit more. Beyond 8 years, it is also growing a little bit. Beyond 8 years, it's growing more. Which tissue is this? Which tissue is this? Tell me which tissue is this. Am I audible more? So this is very true. This is the lymphatic tissue. This is the lymphatic. Am I audible more? This is the lymphatic tissue. You're absolutely right. This is a lymphatic tissue. A clinical correlation with this particular fact. When your lymphoid organs are growing very rapidly, between 4 to 8 years of age, obviously there is a chance that some of the cells of that lymphatic organ might undergo a malignant transformation because they are growing very rapidly. Some cell might acquire a mutation. This is the reason why ALL is seen in this particular age group maximally. This is the reason why maximum ALL cases also tend to occur in this 3 to 10 year age bracket. They also tend to occur in this 3 to 10 year age bracket. Why? Because that's when the growth of the lymphatic tissue in the body is also maximum. And when you're growing maximally, obviously there is a chance that when that cell is rapidly multiplying because of the normal growth, some cells might acquire a mutation that might transform that cell into a malignant cell. All right. So that is the reason why this is the clinical correlate. This is the clinical correlate that the maximum acute lymphoid leukemia, all right, acute lymphoblastic leukemia cases are seen in the 3 to 10 year age group bracket. All right, so this is a clinical correlate. All right, now let's move on towards the next important topic, that is your nutrition. Now let's first discuss some important questions. All these are previous year questions of FMG or slightly modified previous year questions of FMG or NEET PG. All right, so all these questions have a very high chance of getting repeated, and you can see, all of these are not single year papers. They are past 5 years papers. So examiner keeps on repeating same things again and again. Maybe not the exact question, but the funda they will keep on repeating again and again. So you need to understand the funda. All right. Yes, very true. Adenoid with CSM, again adenopathy and adenoids also maximum in that particular age group as well. So now let's discuss this first question. By WHO reference, a child who's having height for age less than -2 standard deviation will be called as. Tell me the answer. Absolutely right. Vijendra is absolutely right. This will be called as stunting. Which is the best method for assessing chronic malnutrition? Which is the best method for assessing chronic malnutrition? Tell me the answer to question number 2. Which is the best method for assessing chronic malnutrition? tell me the answer for question number 2. So I'm saying chronic malnutrition. Chronic malnutrition, best method. Sarthak is right. Aman is wrong. Sky is also wrong. The best method for assessing chronic malnutrition is height for age. And I'll tell you why height for age is the best method for assessing chronic malnutrition. All right, I'll come to that. Height for age is the best method for assessing chronic malnutrition. And height for age less than 2 standard deviation, which is basically chronic malnutrition, is called as, it is referred to as stunting, which all of you answered correctly. Now let's look at this chart. This is a weight for length chart. This is a weight for length chart. All right. Now let's see what the examiner has asked. That a 5-year-old child, the child is how old? 5 year, and initially had a weight of 15 centimeter and a height of 105 centimeter. But then he got measles. Because of measles, what happened? He lost a lot of weight. And now his weight is 11 kg only. Now his weight is only 11 kg. What does this child have? So let's see, let's go into the depth. So basically, initially, height was what? 105 centimeter. 105 centimeter. And what is the weight? So you're not, so this is a weight for length chart. So there is no importance of the five-year part. We just are going to look at the weight for length. All right. So first we are going to assess what is the length. Length we said was 105 centimeter. So this is the 105 centimeter. At 105 centimeter, what is the weight of the child? We said the weight of the child is 15 kg. Initially, the weight of the child is 15 kg. So this is 15 kg. So here, approximately, so this is where initially the child was coming. This is where initially the child was coming. For 105 centimeter, 15 kg. I'll again zoom it for you so that you can understand. This is 15 kg. Can you see? I hope you are able to see. But at 105 centimeter, when I plotted this graph, when I plotted this graph like this, at 105 centimeter, his weight for length is more than -2 standard deviation. It's more than -2 standard deviation. It is more than -2 standard deviation. So initially the baby was normal. Initially the baby was normal because it was more than -2 standard deviation. Now it has become what? Now it has become 11 kg. It has dropped down till here. It has dropped down till 11 kg. It has become here. Now it is less than -3 standard deviation. Now it is less than -3 standard deviation. When the weight for length is less than -3 standard deviation, when the weight for length is less than -3 standard deviation, we call it as severe acute malnutrition. We call it as what? We call it as severe acute malnutrition. We call it as severe acute malnutrition. All right. Now let's discuss this concept slightly more in detail. I'll go a little bit slow right now so that you understand this concept very clearly, and then we'll come back to these 3 questions. Even if you got these questions wrong at this current point of time, there is no harm in that. Let's discuss these concepts and we'll again revisit these 3 questions. All right. So as far as malnutrition is concerned, you can have acute malnutrition or you can have chronic malnutrition. Now think about it very logically. Okay, let's think about it logically. A child is, let's say, 5 years of age or 4 years of age. Okay. Now, till that point of time, the child is perfectly fine. Okay. After 4 years of age, now let's say there is a famine in the region, there is a drought, the parents became poor, or whatever might be happening, and the child doesn't have anything to eat. So what will reduce first? At 4 years of age, the child was very, very typically normal child. You know, ekdam mast khata pita bachcha tha. But at 4 years of age, initially what happened? That the child didn't start to have food. So what is going to reduce first? Weight. Obviously, height won't reduce. Height won't reduce, right? Initially, weight reduces, which is the reason for acute malnutrition. The best assessment is weight for length. The best assessment is weight for length. The best assessment is what? Weight for length. It's fully possible we don't know the age of the child. So we want an age independent parameter. In weight for length, there is no age, right? We can measure the length of the child and we can measure the weight. So in acute malnutrition, the best assessment is weight for length. Because initially, even let's assume we are adults right now, even let's say we get into a famine-like state and suddenly we also don't start to eat anything. What does happen? In the initial 10 days, 20 days, 30 days, our height won't reduce, right? Our weight is going to drastically fall. Same thing is going to happen to a child as well. 3-year, 4-year, 5-year-old child, he doesn't eat food. Acutely, he doesn't eat food. He doesn't get the proper nutrition. What's going to reduce first? Weight is going to reduce first, which is the reason why weight for length is the best assessment for acute malnutrition, which is the reason why acute malnutrition is best assessed by weight for length. Why not weight for age? Because it's fully possible we don't know the age of the child. It's fully possible that we don't know the age of the child and we want to assess acute malnutrition, and we can assess it by taking the length, and for that particular length, if the weight is less than -2 standard deviation, we'll call it as acute malnutrition. So if it is less than -2 standard deviation, is weight for length is less than -2 standard deviation, it is less than -2 standard deviation, the child has acute malnutrition. Child, as far as category is concerned, has moderate acute malnutrition. He has moderate acute malnutrition. He has moderate acute malnutrition. Now imagine that same child. Chronically, for next 1 year, he doesn't have enough food. For the next 1 year, he doesn't have enough food. Then what is going to happen? Obviously, the height of the child is also not going to grow. In that particular case, the height is affected only in chronic malnutrition. Height is not affected in acute malnutrition, which is the reason the best method for assessing chronic malnutrition, the best assessment method is height for age. The best method is height for age. And if the child has height less than -2 standard deviation, then it is called as moderate chronic malnutrition. It is called as moderate chronic malnutrition. Okay, I hope you have understood the difference. Why in acute malnutrition we use weight for length in acute. Why in acute malnutrition we use weight for length, and why in chronic malnutrition we use height for age? Because height is going to reduce for that particular age only if the child is chronically malnourished. Only when the child is chronically malnourished, then is only the height is going to reduce. Acutely, what is going to reduce? Weight is going to reduce, which is the reason weight for length is used for acute malnutrition, which is the reason why weight for length is used for acute malnutrition, If it is less than -2 standard deviation, it is moderate acute malnutrition. If it is less than -2 standard deviation as far as height for age is concerned, it is moderate chronic malnutrition. If it is less than -3 standard deviation, further fall, then this is severe acute malnutrition. Then it is severe acute malnutrition, which is your SAM. If the weight for length is less than -3 standard deviation, then it is called as severe acute malnutrition. And if the weight for length, if the length for age is less than -3 standard deviation, it is called as severe chronic malnutrition. Okay, so weight for length is used for acute malnutrition. Length for age is used for chronic, because chronically only the length is going to increase. Rapidly in the acute phase, weight is going to reduce. When it is less than -2 standard deviation as far as weight for length is concerned, then it would be called as moderate acute malnutrition. And if it becomes even further down, less than -3 standard deviation, it will be called as severe acute malnutrition. While height for age, if it is less than -2 standard deviation, it will be called as moderate chronic malnutrition. If it is less than -3 standard deviation, it will be called as severe chronic malnutrition. Very simple, very easy. Don't take too much of panga. Weight for length is for acute malnutrition. Height for age is for chronic malnutrition. All right. Now there are certain terms that we need to remember. When there is chronic malnutrition and the weight for age is less than this -2 standard deviation, it can be any value, it is called as stunting. So when you have chronic malnutrition and your weight for age your length for age, when you have chronic malnutrition and your length for age is less than -2 standard deviation, that is, you get into the moderate chronic malnutrition zone, or let's say it's even further, it is called as stunting. When the weight for length, that is the acute part, when the weight for length is less than -2 standard deviation, it is called as wasting. It is called as wasting. And even the normal terminology of these words will help you remember it. When the height of the child is not growing, height for age, chronic malnutrition, when the height for age is not growing, we'll say the child is stunted. Stunt ho gaya hai. He's not able to grow in length. Chronic malnutrition, height for age. When immediately the child loses a lot of weight, weight for length becomes less than -2 standard deviation, acute malnutrition, we'll say the child is what? We'll say the child is, he has become wasted immediately. Suddenly he has gotten wasted. All right, suddenly he has gotten wasted. Stunting is a chronic process. Hence, when the height for age is less than -2 standard deviation, we call it as stunting. When the weight for length is less than -2 standard deviation, that is, you are having moderate acute malnutrition, or it's even further, whatever it is, acute wasted, right? Now you'll be like, sir, you have discussed about weight for length, you have discussed height for age. What about weight for age? What about weight for age? Now, weight for age is it has a good thing and a bad thing. What is the good thing? Good thing is it can be used for both acute and chronic malnutrition. It can be used for both acute and chronic malnutrition. That is a good thing. Obviously, if the child is chronically malnourished also, for that particular age, the weight is going to be less. And when he becomes acutely malnourished, then also weight is going to reduce. So both acute and chronic malnutrition can be assessed by weight for age. They can be assessed by weight for age. But it is not best for either of them. Although we can use it for both the things, but it is not good for either of them. It is not the best method for either of them. The best method for chronic is height for age. Now you will be like, sir, why not weight for age? Why not weight for age is because weight for age can be low in acute malnutrition also. So we won't get to know whether the weight for age is low because of acute malnutrition or chronic malnutrition. While only in chronic malnutrition, height for age will get to become low. While only in chronic malnutrition, the height for age will get to become low. This is the reason best assessment for chronic malnutrition is height for age. Then in acute malnutrition, why not weight for age? Why weight for length? That I have told you because weight for length becomes the independent parameter, age independent parameter. So you don't need to know the exact age of the child. That's why weight for length is considered a better parameter as far as acute malnutrition also is concerned as compared to weight for age. So although weight for age is a something which can be used both for acute and chronic malnutrition, but it is not the best for either of them. The best for acute malnutrition is what? Weight for length. And for chronic, height for age. Why? Because in chronic malnutrition, only height for age will reduce, while weight for age will reduce in both acute and chronic malnutrition. So you won't be able to know if the weight for age is low, whether it is because of acute malnutrition or chronic malnutrition. Which is the reason why for chronic malnutrition, we use only height for age. Which is the reason why chronic malnutrition, height for age is considered the best parameter. If everyone has understood, I'll move on towards the next topic. All right, if everyone has understood, I'll move on towards the next topic. That is your severe acute malnutrition. That is your severe acute malnutrition. That is SAM. Severe acute malnutrition is called as SAM. Mishti, if you feel that it is slow for revision, then you can revise on your own. I can go very fast. I can go faster than other what you might desire, but then people won't understand the topics, and it's better to understand it. Maybe take 10 minutes or 20 minutes more and get the question correct in the exam, rather than being very fast and everything going above your head. All right. But if everyone feels that I'm going very slow, I'll pick up my speed. If everyone feels I'm going very slow, then I'll pick up my speed. If everyone feels that no, I'm not going slow, I'm an appropriate speed, I'll go at the current speed. Please let me know. Now let's discuss about severe acute malnutrition. Now let's discuss about severe acute malnutrition, that is SAM. So I've already said that severe acute malnutrition is defined as weight for height less than minus 3 standard deviation. Weight for height, which parameter? Weight for height less than minus 3 standard deviation. Weight for height less than minus 3 standard deviation. But there are 3 other criteria that can be used to say that the child is having severe acute malnutrition. What are these criteria? If the second is if the mid upper arm circumference, where we measure mid upper arm circumference, we measure it at the midpoint between acromion process and olecranon. So the midpoint, that is the mid upper arm circumference. If the mid upper arm circumference is less than 11.5 centimeter, if it is less than 11.5 centimeter, then also we'll say that the child is having severe acute malnutrition. And this mid upper arm circumference is measured by this particular instrument, which is called as the Shakir's tape. It is called as the Shakir tape. Similarly, we'll say that the child is having severe acute malnutrition if there is bilateral pedal edema. If there is bilateral nutritional pedal, there is bilateral nutritional pedal edema, or there is visible wasting, If any of these 4, all 4 nahi, any of this, ek bhi fulfill ho jayega, only one of these is fulfilled, you will say that the child is having what? That the child is having severe acute malnutrition. Another important caveat as far as severe acute malnutrition is concerned, that do not use mid upper arm circumference for children less than 6 months. Do not use it for children less than 6 months. Mid upper arm circumference is only used for children between 6 months to 5 years. So severe acute malnutrition is defined as weight for height which is less than minus 3 standard deviation, or mid upper arm circumference less than 11.5 centimeter, or this is all or. So if any of this is fulfilled, you will call the child as having severe acute malnutrition. All 4 should not be fulfilled. Any one of it is getting fulfilled, you will call the child as having severe acute malnutrition. Alright, now with this understanding, let's discuss these questions which you were getting wrong again. Alright, now these questions will look very easy because you have understood them. By WHO reference, a child having height for age less than 2 standard deviation. Height for age less than 2 standard deviation is chronic malnutrition. It is what? Chronic malnutrition. And we understood as far as chronic malnutrition is concerned, when the height for age is less than 2 standard deviation, the child is not growing in height, child is said to be stunted. So here the option B, which most of you answered correctly, was correct. For chronic malnutrition, the best assessment is, now you have understood why, that because height will only reduce when there is chronic malnutrition, while weight for age can reduce in both acute and chronic malnutrition. Right, which is the reason why height for age is considered as the best method for chronic malnutrition. The next question, 5-year-old child, although we do not require this information, but weight was 15 kg, height was 105 centimeter. Then the height immediately suddenly the weight fell. Then suddenly so it is acute. I told you that in acutely what is going to happen? Height is not going to change, weight is going to fall immediately. So from 15 kg, the child became 11 kg, immediately became 11 kg. And they have given you a weight for height or a weight for length chart. So you are going to plot it. They can give you this chart and you are going to plot it. Initially at 105 centimeter, his weight was 15 kg and it was coming above the minus 2 standard deviation. So basically the child was normal. Because it was less than minus 2 standard deviation, that would have been called as acute malnutrition, right? Weight for length is used for acute malnutrition. But initially it was coming above minus 2 standard deviation. It was here. If you look closely, this is 15 and this was the 105. This was a 105 centimeter line and it was coming above minus 2 standard deviation, which is normal. Between minus 2 to plus 2 standard deviation is what is normal. So initially the child was normal. But now the weight fell from 15 kg to 11 kg. And when he came below 11 kg, he came below even the minus 3 standard deviation. So the weight for length became less than minus 3 standard deviation, which is the definition for what? Which is the definition that the child now has severe acute malnutrition. If the weight for length become less than minus 3 standard deviation, that is severe acute malnutrition. And this is the reason why here we'll call this child as having severe acute malnutrition. Why not moderate acute malnutrition? Moderate acute malnutrition if the weight for length was between minus 2 standard deviation to minus 3 standard deviation. If it was between that, then it would have been moderate acute malnutrition. Stunting is related to chronic malnutrition, so this is gone. Chronic malnutrition is gone. You're acutely losing weight, and now the weight has become less than minus 3 standard deviation. It has become less than minus, the weight for length has become less than minus 3 standard deviation, and hence the correct answer here is severe acute malnutrition. All right, now I think you have understood. I hope no one is going to get these graphs, chronic malnutrition, acute malnutrition, which is used for what, wrong. Again, एक बार रट्टे मार लेते हैं. Acute malnutrition best assessed by, acute malnutrition acute malnutrition is best assessed by what? Weight for length, acute malnutrition. Chronic malnutrition, height for age, because chronically only height is going to reduce, which is used for both. Weight for age is used for both. But why is it not good for chronic malnutrition? Because we won't know whether it is acute malnutrition or chronic malnutrition. It is used for both. Then obviously the differentiating factor is lost. While height for age will only reduce if there is chronic malnutrition. You will lose your height only and chronically you are reduced. Acutely only weight is going to go low. So for acute malnutrition, weight for length is the best. Chronic malnutrition, height for age is the best. When chronic malnutrition is there, we call it as stunting. When weight for length become less than minus 2 standard deviation, we call it as wasting. And when weight for age, it is used for both, but it is not the best for either of them. It is used for both, but it is not the best. It is not the best for either of them. Okay, and we discussed what is SAM, definition of SAM. 4 things come in definition of SAM. Either of them, any one of them is fulfilled, you will call that child as having SAM. If the weight for height or weight for length is less than minus 3 standard deviation, mid upper arm circumference is less than 11.5 centimeter, there is bilateral nutritional pedal edema, or there is visible wasting. Any 4 of these things are there, you will call that a child as having SAM. Mid upper arm circumference is only used in the age group 6 months to 5 years. Do not use it for less than 6 months. And it is measured using what? Shakir tape. It is measured using Shakir tape. Now, what are the complications of SAM? You just need to know the names of the complication of SAMs. They don't go too much into the depth. The complication of SAMs. So you're not eating anything. Think about this. You yourself are not eating anything. What will happen? You will get hypoglycemia. So first complication of SAM is what? Hypoglycemia. It is what? Hypoglycemia. Now food is required to produce heat in the body. No heat generation, hypothermia. No heat generation, hypothermia. Food is required to give protein to the body. Proteins are going to make immunoglobulins. Your immunity is going to go down. And if the immunity goes down, what's going to happen? Infections are going to happen. If you're not taking anything, if there are infections in the gut, what is going to happen? Diarrhea and dehydration might happen. You're not taking anything. Micronutrient deficiency. You're not taking anything. Micronutrient deficiency is going to occur. And last but definitely not the least, obviously, if you're not taking anything, you're not taking any food, the electrolytes in the body are also going to get disturbed. So there's going to be dyselectrolytemia. So these are the 6 complications. These are the 6 important complications as far as SAM is concerned that you should remember. There's going to be hypoglycemia. Just remember the definition of hypoglycemia: less than 54 milligram per deciliter. Less than 54 milligram per deciliter as far as SAM is concerned. There's going to be hypothermia. Obviously, there's no food, you're not able to generate food. There's going to be infection, there's going to be dehydration, there's going to be micronutrient deficiency and dyselectrolytemia. These are the complications of SAM that you need to remember. Now we are going to discuss 2 very important things, that is Kwashiorkor versus marasmus. And I'll make you understand Kwashiorkor versus marasmus that like no one ever has made you understand, so that you never get a question wrong as far as Kwashiorkor versus marasmus is concerned. People tend to get confused. There is nothing to get confused. Two very radically different thing. Let's start with the question. A child is brought to you to a primary healthcare center. Let's say you are in a village in Haryana, you're a village in Uttar Pradesh, you're sitting there. Mother says the child has only been breastfed. The child might be 2 years, 1 year or whatever, but child is getting only breastfeeding. All right. Now on examination, you see what is there. You see that there is bilateral pedal edema plus a dull and lethargic child. Only this 2 information is there. You see that there is bilateral pedal edema and you see the child is dull. What is the diagnosis? tell me the diagnosis. Tell me the diagnosis. Tell me the diagnosis in this particular case. This question, what will be the diagnosis? A, will it be Kwashiorkor? Will it be marasmus? So yes, everyone is telling it correctly. It is going to be option A, that is Kwashiorkor. This is going to be Kwashiorkor. You have a very important information that there is edema. If there is ever given to you edema, think Kwashiorkor. The dull part is also important. Why? Because in marasmus, you end up having irritability, not dullness. The child is lethargic when the child is having Kwashiorkor. The child is irritable when the child is having marasmus. Now let's look at the second question. Adaptive starvation with increased metabolism is seen in. Now tell us the answer to this question. It's seen in Kwashiorkor, is seen in marasmus. Tell me the answer. Now tell me the answer to question number 6. Adaptive starvation is seen where? Adaptive starvation is seen where? Tell me, where is adaptive starvation? Where is adaptive starvation seen? So people are writing it correctly. Adaptive starvation is marasmus. Adaptive starvation is marasmus. Very good. Now again, let's see the next question. Child is irritable. Earlier child was dull. Now child is irritable. Child is brought to casualty, is irritable, has muscle wasting and has a wrinkled skin. This is occurring due to what? Protein deficiency, fat deficiency, caloric deficiency. And I'll tell you that this is a wrong question. This is a wrong question also. But still it is going to get asked in exam, and I'll tell you why this is a wrong question. There's some problem in the question, but examiners love to ask these wrong questions, so you should understand the concept behind the wrong question also. I'll tell you why this is a wrong question, but still, tell me the answer. Child is brought to you, now is irritable, has muscle wasting, has wrinkled skin. This is occurring due to what? So you're right, the answer for this question should be given as, the answer to this question should be given as C. It should be given as option C. Option C is the correct answer to this question, caloric deficiency. But I'll tell you why this is a sort of a wrong question. I'll come to why it's sort of a wrong question, why the answer to this C is the best answer, no doubt, but why it's slightly wrong. I'll come to that a bit later. Here the answer is C. Why? Because this is the condition is describing what? Marasmus. It is describing marasmus. It is describing marasmus. And marasmus we say there is calorie deficiency. In marasmus we say there is calorie deficiency. Next question. This is seen in. So you're seeing what? You're seeing bilateral pitting edema. And bilateral pitting edema will be seen in which case? It will be seen in case of bilateral pitting edema will be seen in bilateral pitting edema is seen in case of this question number 8. Now tell me the answer to question number 8. Correct. So you have edema. We all know if there is no protein, there will be no reabsorption of water. The Starling forces won't act, and what will happen because of that? There is going to be edema. Whenever there is protein loss in our body, when there is protein deficiency in our body, albumin is going to go down. When albumin goes down, the oncotic pressure inside the blood vessel is not going to be there, and the fluid won't be able to get reabsorbed at the venous end, and that will result in fluid retaining in the interstitial fluid, interstitium having high amount of fluid, resulting in edema. So protein deficiency is the correct answer to this question, which all of you are answering correctly. Excellent. So excellent, Syed, excellent, Krishna, excellent stem cells. So good. So you have your concepts correct. Now let's understand the differences. Sorry, last question. Sugar baby appearance is seen in. Sugar baby appearance is seen in. I'll move on towards it's seen in Kwashiorkor. Now let's understand the differences between Kwashiorkor and marasmus. Let's understand the differences between Kwashiorkor and marasmus. Now, someone very rightly said right now that both Kwashiorkor and marasmus, there are actually forms of PM. They are forms of protein energy malnutrition. They are forms of protein energy They're forms of protein energy malnutrition. Now, what is important to understand the difference between kwashiorkor and marasmus is the type of protein which is lost from the body. The type of protein which is lost from the body. In kwashiorkor, what happens? There are two types of protein in our body. You have to understand. There is a visceral compartment of protein and there is a somatic compartment. There is a visceral protein compartment and there is a somatic protein compartment. There are two compartments of protein in our body. Visceral protein basically refers to enzymes in our body, albumin. All the important proteins in our body are visceral protein. Now, somatic protein is the protein which is present in the somatic, that is the muscle. This is basically the muscle. This is basically muscle. Right. Well, visceral protein is basically referring to your albumin, all your enzymes that are there in the body, all the cofactors, everything. All the organic reactions that are taking place in our body, you know, all the neurotransmitters which are proteins and everything, amino acids which act as neurotransmitters, all this refers to the visceral compartment of protein. Well, somatic protein basically only refers to muscle. Muscle mass is what is somatic protein. In kwashiorkor, there is visceral protein loss. There is visceral protein loss. In kwashiorkor, there is what? There is visceral protein loss. That is loss of albumin. There is loss of albumin. And in marasmus, because you're not eating, because there is protein and energy malnutrition, it's a form of malnutrition, there is loss of protein. Here also there is loss of protein. But the loss of protein here is somatic protein loss. There is somatic protein loss, that is loss of muscle. There is loss of muscle mass. The muscles, protein in the muscles, that is what is lost. Now you have to understand that albumin and enzymes, they are way more important for survival. They're required for neurotransmission function, they're required for normal brain functioning. So obviously this visceral protein compartment is more important. This visceral protein compartment, this is more important. This is more important for the functioning of the body, and somatic protein is important, but it is less important. It is less important. Now, whenever you are having malnutrition, you are having protein and energy malnutrition, there are two things which are possible. You can either get into kwashiorkor or you can either get into marasmus. If the body loses the visceral protein compartment, which is more important, then it is obviously bad for the body. Then obviously it is maladaptive. It is not proper adaptation, right? If the body is not getting enough nutrition, you're going to lose protein. So lose from muscles first. Why do you want to lose albumin, which is so important? Why do you want to lose all the enzymes which are so important? This is the reason why kwashiorkor is maladaptation. Kwashiorkor is maladaptation. While marasmus is considered adaptive malnutrition. While this is the reason why marasmus is considered adaptive malnutrition, because if something has to be lost from the body because you're not taking anything, if the protein has to be lost, let it be lost from the muscles first, right? They're not important for survival. Albumin is important for survival. No protein will be transported. Albumin functions as a transport protein. No enzyme will get functional, right? Hemoglobin is also protein. All these things are visceral compartment of protein. You don't want to lose that first. You are at a higher risk of dying. And in case of marasmus, what is there? Somatic protein loss is there. Now, somatic protein loss obviously is less. It is adaptive in nature. It is less important for the body. This is the reason why marasmus is adaptive malnutrition, while kwashiorkor is maladaptive malnutrition. And there is loss of albumin, that is visceral protein compartment, and there is loss of somatic protein, that is loss of muscle as far as marasmus is concerned. And with this concept, you will be able to understand each and everything as far as kwashiorkor and marasmus difference is concerned. All right. So there is kwashiorkor. Now, if there is albumin loss, what is going to happen? The child is going to have edema. The child is going to have edema. This is going to result in ascites, and there's going to be a bulging abdomen. The child face also will swell, resulting in a sugar baby appearance. Because the face also is going to swell. This is called the sugar baby appearance, or called the moon facies, And because visceral protein is lost, the hair is also going to be brittle. There is thin and brittle hair. There is flag sign. There is which sign? There is flag sign. As far as marasmus is concerned, all the protein is lost. So child looks wasted. The child looks wasted, and protein from the, this buccal area protein also is lost. This will result in simian faces, monkey-like faces. This will result in monkey-like. Monkey is called as simian in Latin. So monkey-like faces. There is going to be loss of protein, loss of muscle mass. The skin on this will become wrinkled in nature. The skin will become wrinkled. It will become wrinkled in nature. So now, can you understand? In marasmus, there is somatic protein loss, which is good adaptation, and hence it's called as adaptive malnutrition. And in case of Kwashiorkor, there is maladaptation, visceral protein loss, resulting in a bulging abdomen, ascites, moon-like facies, edema over the face as well. So let's understand the differences. So this is what a child will, Kwashiorkor is going to look like. You will have bulging abdomen. And can you see the dull look of the child? Obviously, like I said, even the neurotransmitters require that protein, and that visceral protein is lost. So child is going to become dull in nature. And this is what is referred to as flaky paint dermatosis. Where you will have normal pigmentation, and then this is dyspigmentation. Normal pigmentation, dyspigmentation. This is referred to as flaky paint. Dermatosis. This also is seen in Kwashiorkor. And this is what is referred to as the flag sign. This is also seen in Kwashiorkor. So there is normal pigmentation, there is dyspigmentation. There is normal pigmentation, there is dyspigmentation, there is normal pigmentation. So flag, normal pigmentation, no pigmentation, normal pigmentation, resulting in a flag-like sign. Again seen in Kwashiorkor. As far as Kwashiorkor is concerned. Alright, so now you have understood the difference between Kwashiorkor and marasmus. Let's write them down. Wasting in Kwashiorkor is masked. It's masked due to edema. Well, in marasmus, it is visible, severe wasting. As far as deficit is concerned, this is a wrong concept, but from exam point of view, let's write it down. In Kwashiorkor, there is protein deficit. In marasmus, there is caloric deficit, because as someone rightly pointed out, in marasmus, there is both caloric and protein deficit. Look, Kwashiorkor, even the neurotransmitters are lost. You are going to be very dull. Marasmus, irritable. Face, moon-like facies, sugar baby appearance. Sugar baby or moon-like facies is going to be there. And marasmus, simian facies is going to be there. Liver. Now in Kwashiorkor, what we typically see that the liver is fatty in nature. Because lipoproteins are not being formed. So fat from the liver is not getting transported to the rest of the body because lipoproteins are not formed, protein is not there. That is the reason fat get deposited in the liver, and hence fatty liver. This fatty liver is not seen in marasmus. Additional signs here are the flaky paint dermatosis and flag sign, which is not seen in marasmus. So now you can understand the difference between marasmus and marasmus and Kwashiorkor. Bilateral edema, dull, Kwashiorkor. Adaptive starvation, marasmus. Irritable muscle wasting, marasmus. Marasmus occurs because of caloric deficiency. Pitting edema, protein deficiency. Sugar baby appearance. Why sugar baby? Because the face is also swollen, so it looks like the child is eating a lot of sugar. That's why his face is swollen. That's why it's so healthy. But this is not healthy. It's just the water which is being retained. That's just the edema which is there. And his sugar baby appearance is seen in Kwashiorkor. All right. So if everyone has understood, I'll now move on towards the next important topic, which is your micronutrients. Now I'll move on towards micronutrients. All right. Now let's discuss about oral vitamin A dose in a 320-day-old child. Now let's discuss about micronutrient deficiency. Let's talk about the dose, oral vitamin A dose in a 320-day-old child would be. Tell me the answer. I've slightly modified the question. This is not exactly the previous year question. I've modified it slightly. Let's see if you are able to answer this question. Answer question number 21 for me. Can you answer this question for me? So you're absolutely right. So 320 days basically means between 6 months to 1 year. Between 6 months to 1 year. And the vitamin A dose between 6 months to 1 year is 1 lakh IU. So option B is the correct answer. This is a very easy question, but they keep on asking this. So I'm asking for revision. I have kept it here. This is what is referred to as the Bitot spots. These are what? Bitot spots seen in vitamin A deficiency. Now let's listen to this very interesting question. A child in Punjab has exclusively been fed a diet of makke di roti. Makke is what? Makke is maize. Basically a maize rich diet. Now the child is having irritability, diarrhea and a skin rash. What is the diagnosis? Tell me the diagnosis. Tell me the answer to this particular question. What is the diagnosis? So Suryansh Bharti is absolutely right. This is pellagra. So maize-rich diet leads to pellagra, and we'll talk about that. Why does that happen? Just a little bit. Just give me a moment. Next question is Menkes disease is caused due to deficiency of. Menkes disease is caused due to deficiency of. Absolutely. So Menkes disease is an autosomal recessive disorder. There is mutation in the gene ATP7A. There's mutation in ATP7A, and it results in copper deficiency. It results in copper deficiency. It results in copper deficiency. Now, which mineral iron deficiency can result in this? Answer this question. Answer question number 25 for me. Which mineral iron deficiency can result in this? Answer the question number 25 for me. Absolutely. So here, this is what the child with acrodermatitis. This is what a child with acrodermatitis enteropathica will look like. And we all know acrodermatitis enteropathica is caused due to what? It is caused due to zinc. It is caused due to zinc. So this is zinc deficiency. All right. Now with this, let's just in a tabular format in one go, let's write everything down. All right. So vitamin A deficiency is known to cause what? It causes night blindness. It causes night blindness. It causes night blindness. It causes toad-like skin, which is referred to as phrynoderma. And vitamin A is a fat-soluble vitamin. It's a fat-soluble vitamin. Now, the WHO grading of vitamin A deficiency is done as XN, X1A, X1B, X2, X3A, X3B. Very important grading, WHO grading of vitamin A deficiency. XN is when there is night blindness. X1A when there is conjunctival xerosis. X1B is when B is there, Bitot spots. This is conjunctival xerosis. All right, X1A is conjunctival xerosis. X2 is corneal xerosis. X3 is when there is ulceration. There is ulceration. There is corneal ulceration. There is corneal ulceration, but it is less than 1/3. Less than 1/3. If it is more than 1/3 of the total area, it is X3P. X3S is when there is scarring. S for scarring, when there is scarring. X3S is when there is scarring. All right. There is F also when there is a fundal changes, but not that important. So this is the WHO grading. XN, night blindness. Night blindness, think about it. Night blindness is what the patient is going to tell you. I'm not able to see at night. This is the first thing. So night blindness, very important to understand. Night blindness is the first symptom of vitamin A deficiency. It is the first symptom of vitamin A deficiency. Conjunctival xerosis is what you will see. So conjunctival xerosis, that is X1A, this is the first sign of vitamin A deficiency. Symptom is what the patient tells. The patient is going to tell you, I'm not able to see at night, night blindness. So night blindness is the first symptom of vitamin A deficiency. What you are going to see, you're going to see conjunctival xerosis, you're going to see drying of the conjunctiva. That is the first sign of vitamin A deficiency. That is the first sign of vitamin A deficiency. Now, as far as vitamin A is concerned, just simply remember that vitamin A is required for epithelial integrity. When that epithelial integrity is not there, what is going to happen? You're going to have toad-like skin. Your skin integrity is not there. Toad-like skin is going to there. When that epithelial integrity is affected as far as conjunctiva and cornea is concerned, that is going to result in, first it is going to result in conjunctival xerosis. Then it will result in corneal xerosis. And further it will, if there is further breach in the epithelial integrity, it will result in what? It will result in ulceration. It will result in ulceration. So just remember, vitamin A is required for epithelial integrity, which is the reason why when there is vitamin A deficiency, skin becomes toad-like. It becomes toad-like, referred to as phrinoderma, and eye changes are, first conjunctiva becomes dry, conjunctival xerosis, first sign of vitamin A deficiency, then cornea becomes dry, corneal xerosis, and then finally when the epithelial integrity is further compromised, what is going to happen? Scarring is going to happen. If it is less than less than 1/3, it is X3A. If it is more than 1/3, it is X3B. All right. Now, as far as treatment is concerned, the dose is concerned, for less than 6 months, we give 50,000 IU. For 6 to 12 months, we give 1 lakh IU, which was the question that was asked. For more than 12 months, we give 2 lakh IU. And we give it on day 0, we give it on day 1, and 2 weeks later. What does this day 0, day 1, and 2 weeks later? Child presents to you with vitamin A deficiency. That day itself, that is day 0, you will give him this particular dose. You give him this particular dose depending upon his age. Next day, you're going to repeat the same dose, and 2 weeks later, you're going to repeat the same dose. 2 weeks later, you're going to repeat the same dose. And as far as prophylaxis is concerned, in the National Immunization Schedule, in the NIS, we start giving vitamin A at 9 months, and we give it every 6 months. We give it every 6 months till 5 years of age. But in that, we do not repeat the dose the next day and after 14 days. That is as far as treatment is concerned. Prophylaxis, we give it every 6 months, just single dose. Okay, now let's discuss about vitamin B deficiency. So vitamin B, B1 is what? B1 is thiamine. Vitamin B1 is what? Is thiamine. Its deficiency will result in what? Its deficiency is going to result in beriberi. Its deficiency will result in beriberi. Now beriberi is of 2 types. There can be wet beriberi and there can be dry beriberi. Wet beriberi. So beriberi and vitamin B1 is required for a lot of your tricarboxylic acid enzyme. That is citric acid cycle. It is important for citric acid cycle. Citric acid cycle is important for energy generation. And this energy, high energy organs in our body are what? Neurons and heart. Now in wet beriberi, heart is affected. So there is heart failure, and this heart failure leads to edema. Water retention, and hence the name wet beriberi. Now if the neurons are affected, if you have neuropathy, then obviously there is no wetness. It is referred to as dry beriberi. Now vitamin B2 is riboflavin. Its deficiency leads to angular cheilitis. Ulcers, that is stomatitis. Angular cheilitis, stomatitis, and very important another thing which I have not taken the picture here. This is what angular cheilitis looks like. It also leads to corneal neovascularization. If you are in a hurry, when you listen to the word cornea, you might think vitamin A. But remember, corneal neovascularization. Corneal neovascularization is seen as far as vitamin B2 deficiency is concerned. Vitamin B2 deficiency is concerned. Now moving on towards vitamin B3, this is your niacin. This is your niacin, which is a part of NAD and NADP. All right, and this results in the very famous pellagra. This results in the very famous pellagra. In pellagra, what do you have? In pellagra, what do you have? You have your 3Ds. That is your diarrhea, dementia, and dermatitis. You have your diarrhea, dementia, and dermatitis. All right, and this is the typical picture. You can see dermatitis here. You can see dermatitis is typically occurring in sun-exposed area. So he might be wearing, must be wearing what? He must be wearing a banyan pehni hogi. He must be wearing a banyan, and that is the reason here the dermatitis has occurred. Here the dermatitis has occurred where he might not be wearing anything, and this area of dermatitis is referred to as Castle's necklace. This is what is referred to as Castle's necklace. All right, this area is referred to as Castle's necklace. Now, what is important to understand that in a human body, even if you're not taking appropriate amount of niacin, tryptophan can get converted into niacin. In human body, if you have adequate tryptophan also, tryptophan can get converted into niacin. The pathway is referred to as kynurin pathway. The pathway is referred to as kynurin pathway, and this requires vitamin B6. This requires vitamin B6, which is your pyridoxine. This conversion requires vitamin B6, which is pyridoxine. So even if when there is tryptophan deficiency, if you're not taking adequate tryptophan in the body, then also you can have niacin deficiency. And this is seen as far as maize-rich diet is concerned. This is seen in maize-rich diet. Maize has lot of leucine. Maize has lot of leucine. High amounts of leucine and very low tryptophan. This leucine does what? This leucine inhibits this tryptophan to niacin conversion, and at the same point of time I already told you that tryptophan is very less as far as maize is concerned. This is the reason why in maize-rich diet you can have pellagra. This is the reason why in maize-rich diet you can have pellagra. You can also have pellagra when, let's say, there are other disorders like Hartnup disease. Let's say there is Hartnup disease. Hartnup disease is when there is neutral amino acid defect. It is an autosomal recessive disorder, and there is neutral amino acid transport defect. The neutral amino acids are not absorbed from the gut. Again, there will be less tryptophan. And when there will be less tryptophan, the Hartnup disease can also result in pellagra. Similarly, if there is serotonin syndrome, or there is carcinoid syndrome. In carcinoid syndrome, what happens? Excess of serotonin is there. There is excess of serotonin. And serotonin is derived from tryptophan. So tryptophan, instead of making niacin, it does not make niacin, it starts making serotonin. Again, niacin deficiency and pellagra can occur as far as carcinoid syndrome is concerned. Whenever there is excess of carcinoid, there is excess of serotonin, tryptophan gets diverted to make serotonin instead of making niacin, resulting in pellagra. Excess of serotonin causing serotonin syndrome because of carcinoid syndrome. When there is excessive diversion of tryptophan into serotonin, that is referred to as pellagra. Then another thing that can lead to pellagra is, I said that this conversion, tryptophan to vitamin B6 conversion, tryptophan to niacin conversion requires which vitamin? Requires vitamin B6. So even vitamin B6 deficiency can lead to pellagra. Now, let's discuss about other vitamins. So pantothenic acid deficiency leads to what is referred to as burning foot syndrome. It leads to what is referred to as burning foot syndrome. Biotin deficiency is when you take raw white egg. Why? Because it binds to biotin. And whenever there is biotin deficiency, there is diarrhea and dermatitis. There is diarrhea and dermatitis. There's diarrhea and dermatitis. Now, moving on towards folate. We know folic acid deficiency leads to what? It leads to macrocytic megaloblastic anemia. And in pregnancy, if you're not taking folic acid, what will it lead to? In pregnancy, if folic acid is not taken, it will lead to neural tube defects. It will lead to neural tube defects. And we know that vitamin B12 deficiency leads to what? It also leads to megaloblastic anemia. It also leads to megaloblastic anemia. Along with megaloblastic anemia, it also causes neural changes, which is referred to as subacute combined degeneration. Which is referred to as subacute combined degeneration. All right. Now, vitamin C deficiency leads to scurvy. It leads to scurvy. It leads to scurvy. What is seen in scurvy? What is typically seen in scurvy? Bleeding gums are seen. Bleeding gums are seen. And scurvy and vitamin C is required for hydroxylation. What is the purpose of vitamin C in the body? It is required for hydroxylation of lysine and proline residues in collagen. So collagen synthesis is affected. This is the reason why you will see gum bleeding. This is the reason why you will see periostal bleeds, subperiosteal bleeds. This is the reason why you will see pain while standing. And at the same point of time, this is what is referred to as scorbutic rosary. And you can see the scorbutic rosary is different from the rosary that you see in vitamin D deficiency because it is angulated and sharp and painful. It is angulated, sharp and painful. Scorbutic rosary is angulated, sharp and painful. Contrast this with rachitic rosary. It is non-angulated. It is not angulated. It is non-angulated, not sharp and non-painful. So vitamin D all results in rickets, and rickets also you have what is called as rickety rosary that has to be differentiated from scorbutic rosary, which has to be differentiated from scorbutic rosary. Scorbutic rosary is painful. Why? Because inside the scorbutic rosary there is going to be hemorrhage, there is going to be bleeding gum, there is going to be subperiosteal hemorrhage also. There is going to be subperiosteal hemorrhage also. Why? Because the collagen is not there. In scurvy, there is defective collagen. There is defective collagen. This is the reason you have subperiosteal bleeds. This is the reason you have bleeding gums. This is the reason you might have some skin bleeding and petechiae also. This is the reason the scorbutic rosary, because there is some amount of bleeding there, it becomes very, very painful. It becomes very, very painful. Contrast this with vitamin D deficiency. In vitamin D deficiency, you have rickets. In rickets, the rachitic rosary that is there, it is not that angulated, it is not sharp, and it is not painful. It is not sharp, it is not painful. In rickets, also you will see what is referred to as Harrison sulcus. This is what is referred to as Harrison sulcus. All right, and you will see genu varum and genu valgum. Now, what is the difference between genu varum and genu valgum? What is the difference between genu varum and genu valgum? Can anyone tell me? Valgum. Valgum. Gum से क्या होता है? Gum is used to stick things together. So the knees are going to be sticking together. Knees are going to be sticking together. Knees are going to be sticking together. This is what is referred to as knock knees. This is what is referred to as knock knees. This is what is referred to as knock knees. Valgum. Gum is used to stick together. So knees will be sticking together. Knock knees. And genu varum. Genu varum. Rum में क्या होता है? Rum is रम. हम रम पीते हैं. रम पी के क्या होगा? हमारी नीज सेपरेट आउट हो जाएंगी, है ना? हम लोग ऐसे ऐसे करके चलेंगे ना रम पीने के बाद. सो नीज विल बी सेपरेटेड आउट. सो इन जीनु वारम द नीज आर सेपरेटेड आउट, एंड दिस इज व्हाट इज रेफर्ड टू एज bow legs. This is what is referred to as Bolex. So now you won't get confused between genu varum and genu valgum. You won't get confused because of genu varum and genu valgum, right? Valgum, gum से चिपक गई knees. Varum, rum पीली. हम लोग एकदम ऐसे चलेंगे. The knees are going to be separated out, right? So genu varum is knees separated out, which is what? Which is Bolex. Genu valgum चिपक गई. They are stuck together. Knock knees. Understood na? ये कोई ना भूलना. Here, this specific picture is genu varum. This is genu varum or Bolex. All right. Now let's discuss about vitamin K. Vitamin K, they keep on asking this question, which clotting factors? You need to remember the numbers of the clotting factors. So the numbers of the clotting factors are, it is required for gamma carboxylation. It is required for gamma carboxylation of 2, 7, 9, 10. It is required for gamma carboxylation of 2, 7, 9, 10. And if these factors are deficient, obviously vitamin K deficiency is going to lead to what? It is going to lead to bleeding, particularly HDN. That is your hemorrhagic disease of newborn. Hemorrhagic disease of newborn. Vitamin K is deficient in breast milk. It is deficient in breast milk. This is the reason when the child is born, we give intramuscular vitamin K. This is the reason when the child is born at birth, we give injection vitamin K of 1 mg intramuscularly on anterolateral thigh, on anterolateral part of thigh. All right, because breast milk is deficient in vitamin K, you won't get vitamin K. You will have hemorrhagic disease of the newborn because vitamin K is required for coagulation factors, for the gamma carboxylation of factors 2, 7, 9, 10. This is the reason why we give vitamin K prophylaxis at birth. 1 mg dose is given intramuscularly. Right. Now, vitamin E deficiency. Vitamin E deficiency. This results in two important things which you should remember. It results in two important things you should remember. One is it results in ataxia, particularly spinocerebral ataxia. And it results in hemolytic anemia. It results in spinocerebellar ataxia and it results in hemolytic anemia. It results in hemolytic anemia. All right. So this is as far as vitamin E deficiency is concerned. Now, as far as micronutrient deficiency is concerned, let's just write down the names. We all know what's there. Zinc leads to what? It leads to acrodermatitis. It leads to acrodermatitis enteropathica. Zinc deficiency leads to acrodermatitis enteropathica. What's going to be there as far as acrodermatitis enteropathica is concerned? There is going to be diarrhea. And there is going to be particular skin rash at the perioral and the perianal region. Perioral and perianal rash. All right, very characteristically. Diarrhea and perioral and perianal rash, and hence the name acrodermatitis. Acro is the acral regions. These are the acral regions, and this is where the dermatitis is occurring. All right, perioral and perianal rash. Selenium deficiency leads to what is referred to as Keshan disease. And characteristic feature of Keshan disease is cardiomyopathy. It is what? Cardiomyopathy. Now, copper deficiency is seen in, we can have micronutrient copper deficiency also, but copper deficiency is seen in Menkes disease. Is seen in Menkes disease. It is an autosomal recessive disorder. ATP7A gene is deficient. Wilson has copper excess. Wilson has copper excess. Copper excess is seen in Wilson disease. While copper low is seen in Menkes disease, which is ATP7A. Wilson is ATP7B. Wilson is ATP7B gene defect. All right. And in Menkes disease, characteristically, there is curling of hair. there is characteristic curling of hair. And iron deficiency, we all know, leads to what? It leads to iron deficiency anemia. It leads to iron deficiency anemia. Okay, curled hair, and as someone rightly pointed out, it is kinky hair. Curling hair, kinky hair, same thing. All right. So that is as far as Keshan disease and cardiomyopathy is concerned. Now let's move on to another important topic that I just wanted to get done with. Milestones. एक बार revise. Milestones is something. Let me. It's already 12:30. So I'll take around 3 hours to complete the entire revision. But milestones के बारे में एक चीज तुम्हें बताना चाहता हूँ. One thing I really wanted to tell you about milestones. Milestones is something which troubles me as a pediatrician also. So I don't expect any person, be it a NEET PG aspirant, FMGE aspirant, to also be very comfortable with milestones because they're tough to remember. All right. No matter what you do, even before coming today also, or whenever no person can say that I remember all the milestones at the back of my hands because they're actually that tough to remember. Now, I'll tell you all about the milestone. That's perfectly fine. You do remember after you keep on practicing them again and again. We are pediatrician, we do it on a daily basis. And obviously most of the milestones are there, but still some milestones we tend to forget. The reason I'm trying to tell you that why that we tend to forget milestones is because I completely expect you guys also not to remember the milestones. All right. And what is important from your exam point of view, that it's okay if you don't remember the milestones 1 week before the exam or 10 days before the exam, but ensure you read them on the last day. Because one question from milestone is almost a guarantee in most exams. Be it INICT, NEET PG or FMGE, irrespective of the exam, one question on milestone is almost a guarantee. All right. So when a question is a guarantee and that question is known to be so damn fucking volatile, in that particular case, I would simply say ki just revise it 1 day before the exam. Even if you have not understood, even if you don't remember it, even if you feel that you are underconfident, that's perfectly fine. Even pediatricians are underconfident as far as milestones are concerned. Revise it 1 day before the exam. Keep it in your notebook, keep it in the 20th notebook or whichever revision material that you're having, and ensure that this is one topic that you revise 1 day before the exam so that you don't mark the answer wrong as far as the exam is concerned. All right. So let's discuss these questions first. So handedness is established at what age? Handedness is established at 3 years. Someone rightly pointed out. A child can walk up and down stairs with 1 foot at a time at what time? What time? This we will discuss. I won't write it down here right now. We'll discuss. Mature pincer grasp is seen at what age? Mature pincer grasp is seen at 12 months. It is seen at 12 months. Now let's discuss the gross motor milestones first, then the rest of the milestones. I'll just keep on quickly writing them down. There's some concept to it. I'll talk about the concepts also, but mostly ensure that you revise it 1 day prior to the exam. Otherwise, there is a full possibility you will get confused within the options. All right. And don't miss out on that one easy question. I'll call it an easy question. Why? Because if you have revised it, it's an easy question. All right. As far as gross motor milestones are concerned, at 3 months, you have neck holding. At 5 months, the child starts to roll over. The child starts to roll over. There is rolling over. Now, for the 6, 9, and 12-month milestones, you can remember that at 6 months, some amount of trunk control occurs. At 6 months, some amount of trunk control occurs. At 9 months, the knees start to have some control. And at 12 months, you start to have some control as far as feet is concerned. So at 6 months, the child, since some amount of trunk control is there, not full trunk control, some trunk control is there. This is the reason at 6 months, child starts to sits but with support. Sits but with support. At 8 months, child is able to sit without support. Okay, at 9 months, now knees are having some control. All right, not full, but some control. So knees, child will be able to stand. So stand, but with support. Stand with support. At 12 months, now feet also have some amount of support. All right, so now the child is able to walk with support. Child is able to walk with support. Now, if a child is able to walk with support, he'll be able to stand independently. He'll be able to stand without support. He able to stand without support. So at 12 months, he is able to walk with support but at the same point of time, standing without support. All right. Two important milestones that are in between. At 8 months, the child also starts to crawl. And at 10 months, the child starts to creep. What is the difference between crawling and creeping? In crawling, the abdomen is touching the ground. Child is moving like a snake. The abdomen is touching the ground. Abdomen touches the ground. And in creeping, the abdomen is not touching the ground. In creeping, which occurs at 10 months, the abdomen is not touching the ground. So I said the child is able to walk with support at 12 months. So at 15 months, the child will be able to walk independently. After walking comes what? At 18 months, the child will be able to run. The child will be able to run. All right. After running, now he's running on a bare plane. At 24 months, he'll be able to go up and down the stairs. At 24 months, he'll be able to go up and down the stairs, but 2 feet at a time. 2 feet at a time. So when he's going up the stairs, what he'll do? He'll put 1 feet, then he'll put the same feet on the same step. Then he'll put another feet, then he'll put another same feet at the same step. When we are walking up and down the stairs, we take 1 feet on one step, then another feet on another step, then another feet on another step. No, they will do 1 feet, 1 step, then another feet on that same. So that's the reason why it's called as 2 feet at a time. 2 feet at a time, 2 feet on the same step. All right. At 3 years, 3 is tricycle. 3 is tricycle. Now, logically think, just simply think, it's easier to go up the stairs as far as balance is concerned as compared to come down the stairs. Because when you come down the stair, you require more balance. It's easier to fall. So at 3 years of age, he is able to go upstairs 1 feet at a time, but downstairs is still 2 feet at a time. Downstairs is still 2 feet at a time. Because when you're going down, you require more balance, right? Otherwise, you will fall. So when he's going upstairs, he is able to use just 1 feet. The child is able to use 1 feet. But coming down, he will keep both the feet on the same step so that he doesn't fall. All right. At 4 years, finally, he can go up and down stairs 1 feet at a time. At 1 feet at a time. So the answer to this question is 4 years. The answer to this question is 4 years. All right. Now let's discuss about at 4 years, another thing starts to happen. The child is able to hop. Hops. Hops has 4 letters, 4 years. At 5 years, the child is able to skips. Is able to skips. Can skips. All right. So skips has 5 letters, skipping, hops 4 letters, 4. Skips is 5 letters. So 5 years, and hops is 4 letters. All right. So this is as far as the gross motor milestones are concerned. This is as far as gross motor milestones are concerned. Okay. Now let's look at the fine motor milestone. Let's look at the fine motor milestones. Now bidextrous grasp comes at 5 months. By bidextrous grasp, I mean if there is an object in front of the baby, both the hands will be used to grasp that object. That is bidextrous grasp. Dextrous, bi. Unidextrous grasp comes at 6 months. This comes at 6 months. All right. Now, as far as unidextrous grasp is concerned, imagine this is the object that the child has to bow. Initially, the unidextrous grasp, normally when we want to grasp it, how will I put it? I will do it like this. I will put it like this. This is what adults do. This is mature. Child won't start like that. At 6 months, he will first use the ulnar aspect of the hand. So the unidextrous grasp at 6 months is ulnar aspect. It's ulnar aspect. All right. Then he will do what? Then the radial grasp will come. Then the radial grasp is going to come. Then the radial grasp is going to come. Then he is going to have immature pincer grasp. So pincer grasp is this. holding a pen is mature pencil grasp. Just the index finger and the thumb is being used. Immature pencil grasp is when he's using these two things, but he's taking the support of other fingers also. So when he's putting it like this or putting something like this, that is immature pencil grasp. And when you're able to use just the thumb and the index finger, that is mature pencil grasp. That is mature pencil grasp. I'll take the example of a pen. Take the example of a pen. Pen is better. Initially, there is ulnar, say he will, at 6 months, he will take it from the ulnar aspect. Then he'll start taking it from the radial aspect. Then at 9 months, immature pencil grasp is going to come. He's using the thumb and the index finger, but he's taking the support of the other fingers as well. So immature pencil grasp. And at 12 months, mature pencil grasp. Just the thumb and the index finger is there. All right. So the 6 months, this grasp is the ulnar grasp. This is ulnar grasp. All right, this is ulnar grasp. Radial grasp occurs at 7 months. Radial grasp occurs at 7 months. Pincer grasp, immature pincer grasp occurs at 9 months. Immature pincer grasp occurs at 9 months. Mature pincer grasp will occur at, as everyone rightly pointed out, 12 months. Rightly pointed out, it will occur at 12 months. Now, if the baby is able to hold a pen at 12 months, by 15, what will he start to do? He'll start to scribble. So at 15 months, the child starts to scribble. What is scribbling? Scribbling is doing things like this. He'll have a pen in the hand and he'll start to do things like this. This is what is scribbling. So scribbling will start at 15 months of age. Scribbling will start at 15 months of age. Now, after scribbling, obviously, the child will start to draw. He'll start to draw proper things. Let's see the drawing milestones. At 2 years of age, 2 points. So straight line. All right. At 3 years of age, he'll be able to draw circle. He'll be able to draw a circle. At 4 years of age, so you can remember it like this. At 4 years of age, a cross. He'll be able to draw a rectangle or a square at 4.5 years. Square and rectangle. Square drawing occurs slightly later as compared to rectangle. Just remember that. And at 5 years of age, there is triangle. There is triangle. All right. Plus sign or the cross sign. All right. Now, next is diamond. Diamond appears at 6 to 7 years. 6 to 7 years. Now, let's look at some fine motor milestones as far as buttoning and dressing is concerned. So, he'll be able to, the child will do undressing with help. He'll do undressing with help. See, it's easier to undress. Think in a bad way or in a, sort of naughty way also. It's always easier to undress than to dress up, right? So, undressing with help will start at 2 years. It will start at 2 years. It will start at 2 years. Dressing with help obviously will occur later. It will start at 3 years. It will start at 3 years. Now, if you're dressing with help, you will be able to undress without help. You will be able to undress. So, unbuttoning will be able to be proper, and this will be at 3 years. He'll be able to proper button himself up at 4 years, and complete undress and dressing without help will be seen at 5 years. It will be seen at 5 years. And tying shoelaces, because you are doing everything now independently, it will again be at 5 years. So while buttoning he'll be able to do at 4 years, complete undress and dress without help will be seen at 5 years, because now you'll be able to tie the shoelaces as well. So complete undressing and dressing without help will be at 5 years. All right. So undress with help at 2 years. Dressing with help obviously means that he will be able to undress without help. That is, unbuttoning will start at 3 years. Both will start at 3 years. Buttoning will start at 4 years, and a complete undressing and dressing without any help will start at 5 years. Now, social milestones, as far as social milestones, let's discuss about social milestones. At 2 months, what social milestone is going to come? At 2 months, social smile is going to come. At 3 months, the baby is able to recognize the mother. At 6 months, 6 letters, mirror play will start. At 7 months, 7 letters, stranger anxiety is going to be there. At 9 months, the child is going to wave bye, bye, bye. 9 months, bye, bye, bye. All right. At 12 months, the child kisses on request. The child kisses on request. All right. At 15 months, two P's develop. What are the two P's? He will be able to point towards an object, and he will be able to point towards peeing. All right. So he will be able to wet himself, and he'll say that he has wet himself. He'll point towards peeing. All right. And he'll point towards an object at 15 months. At 18 months, two D's are going to occur. What are these two D's? These two D's are domestic mimicry and dry at day. So at 15 months, he was able to point that, okay, he has peed his pants, please change my pants. But at 18 months, he will be dry at day. He'll himself, he will just tell that he's going to the toilet, because he won't wet himself at day. He will wet himself at night at 18 months, but not at day. 2 years, there is going to be what is referred to as parallel play. There is going to be referred to as what is referred to as parallel play. What is parallel play? If you put two children in the same room of 2 years each, they won't play with each other. They'll play independently. This playing independently is what is referred to as parallel play. At 3 years, he'll be able to name 3 things about himself. What are these 3 things? He'll be able to tell his name, his age, and his gender. So he'll be able to tell, I'm Aditya, I'm 29 years old, and I'm a male. All right. These 3 things the child will be able to say at 3 years. As far as playing is concerned, now they will be able to play with together. There will be cooperative play. There's going to be cooperative play. And at 4 years, there is going to be role play. There is going to be role playing at 4 years of age. Now let's look at some important language milestones. Let's look at language milestones. At 2 months, the child coos. So 2 O's, 2 months. At 4 months, the child does what? Child does ha, ha. That is laughing out loud. Ha, ha. 4 months. At 6 months, the child will be able to say monosyllables. Ma, ba, da. Ma, ba, da. 9 months, he'll be able to say bisyllables. Mama, baba, dada. And at 12 months, he'll finally be able to say one word with meaning. One word with. Finally be able to say one word with meaning. At 15 months, 15 has 5 in it. So his vocabulary will be 4 to 6 words. 4 to 6 words. All right. At 15 months, the vocabulary is going to be 4 to 6 words. And at 15 months, what starts is what is referred to as jargon speech. Jargon speech. Very, very important. At 15 months, what starts? Jargon speech starts. Okay. Jargon speech is he will speak words which don't have any meaning. His own words, which do not have any meaning, he'll start speaking them. Something on those lines he'll speak. That is what is referred to as jargon speech. All right. 18 months, 8 is there. So 8 to 10 words. Vocab. 8 is there. So 8 to 10 words as far as vocabulary is concerned. All right. At 8 to 10 words, at 18 months, there will be 8 to 10 words vocabulary. And at 18 months, what's important to remember, at 18 months, there is what is referred to as picture naming is there. Picture naming is there. All right. At 2 years, the vocabulary has increased. 2 years, the vocabulary has increased. It becomes 50 to 100 words. It becomes 50 to 100 words. And the name 2 itself is telling you everything. 2-word sentences are going to be there. How many? 2-word sentences are going to be there. This jargon speech is very important, has been asked repeatedly. 15 months, remember jargon speech. And at 2 years, 2-word sentences. What is 2 years? What are 2-word sentences? Come here, idhar aao, udhar jao. 2-word sentences he'll be able to speak at 2 years. At 3 years, I already told you he'll be able to say his name, age, and gender. He'll be able to say his name, age, and gender. And he also starts to use his pronouns. I, me, him, all these pronouns, I, me, him, he'll be able to use, he'll be able to use pronouns, and he's able to repeat 3 digits. Repeats 3. He's able to repeat 3 digits. All right. As far as 4 years is concerned, 4 poem. Poem has 4 letters. He'll be able to recite a poem. He'll be able to do what? He'll be able to recite a poems. And at 5 years, he starts to ask meaning of words. Very important. He starts to ask meaning of words. At 5 years, he starts to ask meaning of words. They sometimes ask about when does a child start to use past tense and future tense. So at 4 years, he's able to use past tense. And at 5 years, he'll be able to use future tense. He's able to use future tense, past tense and future tense. So another thing that you have to remember, 4 years is past tense, 5 years he's able to use future tense as well. All right. So this is as far as the language milestones are concerned, and we have done with language. We are done with language milestone. Now let's discuss a little bit about breast milk. Let's discuss a little bit about breast milk. Easy topic, but very frequently repeated. That's why I'm covering it. Breast milk is deficient in which of the following? We all know breast milk is deficient in 2 vitamins. It is deficient in 2 vitamins. Which 2 vitamins is breast milk deficient in? Please let me know immediately. So we all know breast milk is deficient in 2 vitamins. Which 2 vitamins is it deficient in? Which 2 vitamins is breast milk deficient in? Which 2 vitamins is breast milk deficient in? Tell me fast. Tell me the 2 vitamins. So yes, one is vitamin D. What is the other vitamin? What is the other vitamin? Absolutely, the other vitamin is vitamin K. चलो I'll just say one thing to easy okay life. I saw the message right now actually. पहले यार hypocrisy की spelling सीख ले, उसके बाद मेरे को बताइए और एक बार ढंग से वीडियोस देख ले. Hypocrisy मैंने कुछ नहीं की है. नुआंस लोगों को पता नहीं होता. नुआंस के लिए थोड़ी हाई IQ चाहिए होती है. मैं कोचिंग के कभी अगेंस्ट नहीं था. मैं मिस सेलिंग के अगेंस्ट था. मेरी लास्ट वीडियो देख लेना. I was against saying that ये कोचिंग कर लो तो एग्जाम निकल जाएगा. I was against that. I was against कि हजार घंटे पढ़ाते रहो, रिवीजन ना कराओ. I was against that. Alright, एक बार देख लेना. मैंने खुद भाटिया से कोचिंग ली है. मैंने खुद भाटिया का TND ज्वाइन किया है. And I feel proud to say that जिस कोचिंग से मैंने खुद कोचिंग ली थी and I enjoyed that coaching. I'm here now not as a student but as a teacher. ठीक है? देखो तो हिपोक्रेसी की स्पेलिंग तक नहीं आती. बात करते हैं. Anyhow, so breast milk is deficient in vitamin D and vitamin K. All right, very important point. Very frequently tested point. This is the reason why vitamin D is given as drops. It is given as drops, and vitamin up to 1 year of age. Up to 1 year of age after the birth of the baby. And vitamin K ka to hum log, I've already told you, we give an injection vitamin K1 1 mg. As everyone rightly pointed out, we give injection vitamin K1 at birth 1 mg. All right. So we have discussed this. Breast milk is deficient in which of the following? Answer is going to be vitamin K. Now, vitamin K is deficient is given to newborns to prevent what? So we already know this. Vitamin K is given. Just one second. So vitamin K is given to newborns to prevent what? We all know this. It's given because vitamin K is required for gamma carboxylation. It is given for vitamin K is given for gamma carboxylation is important for gamma carboxylation of factors 2, 7, 9 and 10. We all know this, right? So this is given to prevent what? Those factors are important for clotting. Clotting is not going to be there. Hemorrhagic disease of newborn is going to be there. What is going to be there? Hemorrhagic disease of newborn is going to be there. Now, which of the following is a contraindication to breastfeeding? Which of the following is a contraindication to breastfeeding? This is a very important thing. This is a very important thing. All of the following are technically contraindications to breastfeeding. Then how do you choose the answer? Tell me the answer to this question number 33. All of them are technically contraindications to breastfeeding, but only one of them is the correct answer. Please tell me what is the correct answer. And छोटा डॉक्टर ने बड़ा सही आंसर दिया. Right? So it is galactosemia. I'll tell you why. HIV, CMV, and mastitis, these three are what are referred to as relative contraindications. They are what is referred to as relative contraindications. They are relative contraindication. Galactosemia is an absolute contraindication. Galactosemia is an absolute contraindication. In case of an HIV positive mother, if the baby is taking antiretroviral therapy, we're giving nevirapamine to the baby or nevirapamine plus zidovudine, that is as far as ART is concerned, that's not what we're going to discuss right now. Then the mother can breastfeed the baby. It is preferred that the mother does formula feeding or uses some other form of feeding, but mother can breastfeed. And in a developed country, HIV is considered a contraindication. In a developing country like India, the recommendation says that an HIV mother can and should breastfeed. Same goes for CMV also. It is a relative contraindication. Same for mastitis. If mastitis is there in one breast, you can always feed from the other breast only. Right? All these are relative contraindications. Similarly, other infections like herpes and TB. Basically, all the infection, herpes and TB, all these are relative contraindication. All these are relative contraindications. They are not absolute contraindication. Galactosemia is a absolute contraindication because in galactosemia, the galactose from the lactose will cause problem with the baby, will cause developmental delay, will cause, the child having seizures, neonatal hypoglycemia, and all that kind of stuff that we know about galactosemia. You know about galactosemia from biochemistry, I hope. So, won't go into that, but galactosemia is an absolute contraindication. It's an absolute contraindication to feeding, to breastfeeding, All right. Now, which of the following statement is not true about colostrum? Tell me the answer. So this is slightly controversial actually. So colostrum we know कि कहते हैं कि rich in fats होता है, but इसमें best answer बताऊँ क्या होगा? इसमें best answer rich in fats होगा. इसमें best answer rich in fats होगा. Best answer here is going to be rich in fats. So we know colostrum is rich in what? It is rich in immunoglobulin A. It is rich in immunoglobulin. Immunoglobulins are what? Proteins. And it is yellow in color. Here, rich in fats is going to be the better answer. But this is, I would say, this is a slightly controversial question because all things are actually correct about colostrum. It is rich in fats, rich in proteins. It is low in lactose actually. All right. So, but अगर मेरे को एक best option choose करना होता, मैं rich in fats choose करता because rich in proteins and IgA are same things. Rich in proteins and IgA same things. Immunoglobulin is what? It is a protein. So it is rich in proteins, right? And yellow color तो हमें पता होता ही है. So rich in fats would be the better answer, but I would say this is a controversial question. This is a controversial question. This is a controversial question. Some people might give the answer as rich in protein. So both A and B can slightly be true also. Some may say that only immunoglobulin is there. I won't consider that as a protein, and the rest of the protein is less as far as colostrum is concerned. I would take the answer as A, but there might be some other faculty who might give the answer as B also. We both are correct. It's not. This is an example of a controversial question. So I wanted to keep one controversial question, but I would keep A as a better answer. All right. Now, which of the following is prescribed as drops to newborns since breast is deficient in it? Since breast milk is deficient in it. The answer is here. The question is asking drops. So the answer is going to be vitamin D because vitamin K is given as an injection. Vitamin K is given as an injection. Now let's discuss about breast milk a little bit. All right, let's discuss about breast milk a little bit. Now, breast milk, when you're feeding the baby, there is what is referred to as foremilk and hindmilk. What is referred to as foremilk? Foremilk is what comes first. Foremilk is rich in water. Foremilk is rich in water. It satisfies the thirst of the baby. It satisfies the thirst of baby. Initially, the baby, when it's taking the milk, he's very thirsty. So the first milk that comes is rich in water, satisfies the thirst. Later comes fat. Hind milk is rich in fats. It satisfies the appetite or it satisfies, it's important for satiety. All right. Now, breast milk is divided into three main categories. First, the first 72 hours, you have what is referred to as colostrum. Then till 2 weeks, you have your what is referred to as transitional milk. And beyond 2 weeks, you have your mature milk. Now, colostrum, we all know, is rich in immunoglobulin A, it's rich in fats, and it's rich in proteins. But like I said, consider fats to be the better answer in that particular question. It has less lactose. It has less what? It has less lactose, and the color is what? Color is yellow. Color is yellow. And as the milk progresses, there is increase in lactose amount. As the milk becomes more mature, there is an increase in lactose amount, and the amount of fat and protein starts to reduce. The amount of fat and protein starts to reduce. There is an increase in the lactose amount as the milk becomes more and more mature. All right. Now, last thing is the differences between human breast milk and cow milk. Between human breast milk and cow milk. Now, content-wise, protein is only 1 gram per deciliter in human milk. In cow milk, it's actually high. It is around 4 gram per deciliter. But this is more absorbable. This is more absorbable and better quality protein. And better quality protein. And better quality protein. We all know the weight builders keep on saying, whey protein low, whey protein low, whey protein low. This is valid as far as human breast milk also is concerned. Here, the whey to casein ratio is 80 is to the whey to casein ratio here is 60 is to 40. It is 60 is to 40. That whey is much more as compared to casein, and it is more easily absorbable. The whey is more easily absorbable. In cow milk, the ratio is different. Here, in this case, it is 20 is to 80. Whey is less as compared to casein, and this casein forms a coagulum. It forms a coagulum, and because it forms a coagulum, it is not absorbed. It is not absorbed. So even though the human breast milk as compared to cow milk has lesser protein, it is more absorbable and a better quality protein. It is more absorbable and a better quality protein. All right. Now, as far as phosphate is concerned, the calcium to phosphate ratio in human breast milk is 2 is to 1. And this does what? It promotes calcium absorption. It promotes calcium absorption. In cow milk, the phosphate is higher in amount. The phosphate is higher in amount. And this does what? It creates problem in calcium absorption. It creates problem in calcium absorption. In fact, one of the major causes of late onset hypocalcemia is giving cow's milk. Cow milk is an important cause of late onset hypocalcemia. It's an important cause of late onset hypocalcemia. Why? Because high amount of phosphate, it binds to calcium and doesn't allow the calcium to absorb. All right. Now, fats in human breast milk are rich in DHA and PUFA. They are rich in PUFA and DHA. This DHA is important for brain development. This DHA is important for brain development, and they're not found or much less quantity as far as cow milk is concerned. Carbs are more in breast milk. They are at 7 gram per deciliter, while here it is only 4 gram per deciliter. More in breast milk. More in breast milk. So these are the important differences. The most important differences that you have to remember that the cow milk, the protein is poorer quality, more casein, less absorbed. It has lesser amount of DHA, lesser amount of fats, polyunsaturated fatty acids, which are required for brain development. Brain development occurs better with mother's milk, and higher amount of phosphate is there in cow's milk, which does not allow calcium to get absorbed, and higher amount of lactose is there. Higher amount of lactose, that is carbs, are there as far as human breast milk is concerned. All right. And these are the 4 signs of good attachment. These are the 4 signs of good attachment which can be asked when the baby is attached to the nipple. Obviously, the mouth should be wide open. Otherwise, not a proper attachment. Obviously, the mouth should be wide open. Second is, since the baby is very close to the mother, the chin should touch. The chin should touch the breast. The chin should be touching the breast. Obviously, if the mouth is open, the lower lip is going to be everted. Lower lip is turned everted. Lower lip is everted, and most of the areola should be inside the mother's. Should be inside the mouth, and only the upper areola should be visible. Only the upper areola is visible. Lower areola should be inside the baby's mouth. only the upper areola should be visible, and lower areola should be inside the mouth. So these are the signs of good attachment. Obviously, the mouth should be wide open. Mouth is wide open, lips are going to be everted. Baby is close to the mother, the chin will be touching the breast, and only the upper part of the areola should be. Phosphate में मैं ये कह रहा हूँ that in case of human breast milk, the calcium is more than phosphate. 2:1 ratio. So this 2:1 ratio, because phosphate is less, calcium is more, promotes calcium absorption. In cow's milk, phosphate is more. The ratio is not important, but phosphate is definitely more. Because this phosphate is more, calcium absorption becomes less. Okay, this is the main point as far as cow's milk is concerned. Calcium is not absorbed properly as far as cow's milk is concerned, while calcium is in a 2:1 ratio in human breast milk, which is the reason why it is absorbed more easily in a human breast milk. Now, as far as absolute contraindication to breastfeeding is concerned, there are only two absolute contraindications that you need to remember. The one is, which I already discussed, that is your galactosemia, which all of you rightly mentioned. The second is if the mother is on radiotherapy or chemotherapy. Basically, if the mother is undergoing cancer treatment, then breastfeeding is definitely contraindicated, because the cancer killing drugs will kill the cells inside the baby also, so don't give. There are certain other drugs which are where you're giving mother, again a form of chemotherapy in some way. If you're giving those drugs, again the baby is contraindicated and the baby does not take breastfeeding. So chemotherapy, radiotherapy and galactosemia, these are the absolute contraindication. HIV, CMV, herpes, all these are relative contraindications. Very important to remember. Now let's discuss about, in neonatology, there are three things that are important. One is your neonatal resuscitation protocol, NRP. For NRP, I will say this is one of those few topics which I won't consider for revision. Why? Because it requires proper 1 hour. It requires proper 1.5 hour. And it's my genuine request to you that it's okay if you give 1 hour to NRP. For revision also, if you give 1 hour to NRP. But because it's such a big topic for revision, I won't cover it here. But I will ask you guys that do NRP from some whichever platform that you're using, or whichever, if you're using Bhatia, then definitely do the NRP from that video from NRP, that 1 hour video, definitely do it. All right. Because there are very, very minute nuances that you might need to remember. So wo proper ek baar kar lo. There is no harm in that. All right. I don't want to cut short NRP. Other things can be cut short a bit, still made high yield. Everything in NRP is actually, high yield. The other two important things that they love to ask, which I'll be discussing, two important small topics which they love to ask are infant or diabetic mother, and your congenital diaphragmatic hernia. These are the two questions. Let's see. Infant of diabetic mother is at the risk of development of. This is a question which has been asked in AIMS May 2018. This question was asked to the exam which I cleared. I got it wrong. I'm so sorry. Because the options were actually close. They weren't these options. There were some other options. I got confused. I think I did not attempt the question, but मैंने गलत किया था. I'm telling you that these easy questions also, even the toppers sometimes get wrong. हो जाता है कभी-कभी. And next question is, bag and mask ventilation is contraindicated in which of the following condition? So this is a AIMS question. This is a FMG repeat question. This is a NEET PG repeat question. So very, very important. Infant or diabetic mother for any exam. You'll clear FMG this time. Next year or you will give NEET PG. So you should know. And bag and mask is contraindicated in which of the following conditions? 43 का A है. 43 का everyone is right. A है. Hypocalcemia. 43 का A है. And इसका आंसर क्या है? 44 का आंसर क्या है? What is the answer to question number 44? What is the answer to question number 44? 44 का B is correct. I already told you we are going to discuss about congenital diaphragmatic hernia. All right, 44 का B is correct. So now let's discuss about these particular things, that is infant or diabetic mother and and we'll discuss about congenital diaphragmatic hernia. Now, infant of diabetic mother is very, very simple. Pehla concept. Mother has diabetes. This mother, diabetic mother, can be a pre-gestational or gestational diabetes. So it can be pre-gestational diabetes mellitus or gestational diabetes, that she's mother getting diabetes during pregnancy. Obviously, pre-gestational diabetes mellitus, there are higher chances of having congenital malformation. There are higher chances of having congenital malformations. Why? Because in pre-gestational diabetes mellitus, the high amount of glucose is there during the first 8 weeks of life. And we know that organogenesis and embryogenesis takes place during the first 8 weeks of life. That is when there will be high glucose levels. And that is when those high glucose levels are going to act like a teratogen and cause teratogenicity and cause congenital malformations. While in gestational diabetes mellitus, the high glucose levels and the spike of glucose occurs in the second and third trimester. And that is the reason when already organogenesis has already taken place. This is the reason in gestational diabetes mellitus, there is lower chance, decreased chance of having congenital malformations, while higher chances are seen as far as pre-gestational diabetes mellitus is concerned. Understood the concept? Pre-gestational mother already has high glucose level. So in the first 8 weeks, high glucose levels, higher chances of congenital malformation. Gestational diabetes mellitus, second and third trimester you start to have your high glucose level. By then already organogenesis has already occurred. So lesser chances of having congenital malformations. Now why does this high glucose level cause problems? So the hypothesis, basically the name of the hypothesis is not important. It's called as Penderson hypothesis. Penderson hypothesis, I'll write it down. Penderson hypothesis, name hasn't been asked, but basically the hypothesis says that if there is high glucose level in the mother has high glucose level, obviously this glucose is going to get transported into the fetus. It's going to get transported in the fetus and the baby. Now in the baby, when there is high glucose level, in response to this high glucose level, what is going to happen? The pancreas is going to secrete high amounts of insulin. The pancreas is going to secrete high amount of insulin. And there will be a state of hyperinsulinemia as far as the baby is concerned. Insulin is an anabolic hormone. It is a anabolic hormone. It will do what? It will cause fat deposition. Because there is fat deposition in the baby, what is going to happen? The baby is going to be large for date. The baby is going to be large for date or large for gestational age. It will be a large for date baby. The baby's weight will be more than 4 kgs in some cases. So it will be a macrosomia. There will be macrosomia and it will be a macrosomic baby with birth weight more than 4 kgs. Alright. So this is going to happen because of hyperinsulinemia. Now, because of this hyperinsulinemia, 2 other metabolic defects also occur. If there is high insulin, what is going to happen? The baby will have hypoglycemia. The baby will have hypoglycemia. The second thing the baby is going to have is, which you all answered very correctly, hypocalcemia. Second most common metabolic defect is hypocalcemia. So there is going to be hypocalcemia. Why does hypocalcemia occur? There are 2 reasons why hypocalcemia occurs. The first reason is that insulin, this excess amount of insulin is known to inhibit PTH secretion. So this does what? It inhibits PTH secretions. It inhibits PTH secretion. So calcium levels go down. Second thing is the baby is very large for date and very macrosomic. So whatever the stores are there in the body of the baby when he's born, they're not adequate for the body. So large for date body, large macrosomic baby requires more calcium. Baby doesn't have that many calcium stores. Hypocalcemia. Similarly, the second thing, insulin does what? It inhibits PTH secretion. These are the reason why the first most common abnormality, metabolic abnormality, is obviously hypoglycemia. The second most common is hypocalcemia. Now, there are certain congenital malformations that can occur. The one that I'm going to discuss is problems in heart. The most common congenital malformation as far as heart of infant or diabetic mother is concerned is VSD, ventricular septic defect. The most specific is TGA, transposition of great arteries. As far as CNS is concerned, the most common are your neural tube defects. The most specific is your caudal regression syndrome. Very, very important. Caudal regression syndrome is the most specific. Most common is neural tube defects. All right. And you guys are absolutely right about this. You guys remembered it. So great. VSD is the most common one and TJ is the most specific one.
CNS most common is neural tube defects, and most specific is caudal regression syndrome. It's caudal regression syndrome. There's one more thing that I want you to remember. There is something called as lazy left colon, which can occur in children, of infant or diabetic mother. And this can result in, obviously name itself is saying you lazy left colon. So there's going to be some motility problem, and this can result in delayed meconium passage. This can result in delayed meconium passage. All right. Now let's discuss about congenital diaphragmatic hernia. The name itself is telling you. So these are your lungs. There is your diaphragm. And then you have your intestines. You have your intestine or a gut. The function of diaphragm is what? It separates the thoracic cavity. From the abdominal cavity. If there is a diaphragmatic hernia, congenital diaphragmatic hernia, what is going to happen? All these intestines, they will come into the thorax. And this is what is seen as far as X-ray is concerned. You can clearly see all the intestine and stomach. You can see the gut in thoracic cavity. This is a typical chest X-ray. I'll remove all the annotations, but see it. This X-ray, very, very important X-ray. You have your gut in thorax. Now, if you have your gut in thorax, what is going to happen? The lungs won't be able to grow. This will result in what? This will result in pulmonary hypoplasia, which is the most common cause of death in these children, most important cause of death in these children. The gut comes into the thorax, the lungs are not able to grow, and as a result, what happens? There is pulmonary hypoplasia that results in death. All right. Now, the most common site is posterolateral, left posterolateral, and most common type is Bogdalek hernia. Which occurs in the posterolateral and the left side. All right. Now, this leads to, I've already told you, it leads to pulmonary hypoplasia. And when the gut is there in the thorax, the gut is going to be malrotated. So there is going to be intestinal malrotation. So pulmonary hypoplasia will result in respiratory distress, and this intestinal malnutrition will result in obstruction-like symptoms. So there is going to be vomiting, there's going to be abdominal distension, like that. All right. So this is the pathophysiology of congenital diaphragmatic hernia. I already told you the most common cause of death is pulmonary hypoplasia, and the most important significant prognostic marker is also what is referred to as LHR. This is the lung head circumference ratio. Obviously, if the LHR is low, if it is less than 1.5, it predicts a poor prognosis. Basically showing that the lungs haven't developed. If the head and lungs, if the lungs are smaller, it obviously is going to show that the lungs haven't developed, and since the lungs haven't developed, the LHR is going to be low. If it is more than 1.5, there is better prognosis. So lung hypoplasia is the most important prognostic or mortality marker. Okay. So this covers your congenital diaphragmatic hernia. Now let's discuss a little bit about, some important genetic syndromes, and then we'll essentially get concluded with the class. Anti-mongoloid facies, short stature, undescended testis, and pulmonary stenosis. What is the diagnosis? Tell me, what is the diagnosis? So D is not the correct answer. D is not the correct answer. Yes, A is the correct answer. A is the correct answer. Noonan syndrome is the correct answer. Noonan syndrome is the correct answer. And the giveaway was this: pulmonary stenosis. All right, undescended testes. So Noonan syndrome is what is sometimes referred to as male Turner syndrome, but this is a misnomer. This is a misnomer. But we'll discuss about this a little bit later. The second question I'm going to discuss is, tell me the answer to this question. What is the diagnosis? What is the diagnosis? What is the diagnosis? So Prince is right again. So 18, there is trisomy 18. There is trisomy 18. And trisomy 18, this was Edward syndrome. Option B, Edward syndrome. All right. So now let's discuss. First thing is, they keep on asking what are the differences between Edward versus Patau. Edward versus Patau, they keep on asking the differences. So it's very important. So you have to understand the psyche of the examiner. थोड़ा सा ना psyche examiner की समझनी होती है. तुम Edward रटते रहो, you will keep on forgetting. You keep on trying to remember Patau, you will keep on forgetting. There are certain things which are common, you will mix them up. Don't do it like that. Understand what is different. ये Edward में होता है, Patau में नहीं होता. This happens in Patau, this doesn't happen in Edward. If you're able to tabulate the differences, you will remember it more easily and you'll be able to solve the questions also more easily. Alright, so let's see the differences between Edward and Patau syndrome. Let's see the differences between Edward and Patau syndrome. So Edward syndrome occurs because of trisomy 18. E for election. E for election. So you become eligible for election on 18 years of age. P for puberty. P for puberty. And puberty occurs at 13 years, so trisomy 13. Trisomy 13. Now cleft lip and cleft palate. Edward either no or a plus or minus. Basically not seen. Patau is a plus, very commonly seen cleft lip, cleft palate. Alright, I'll put it as not seen only. I'll put it as not seen only for you or your understanding. Now, as far as fingers are concerned, Patau has P has polydactyly, multiple fingers. Has polydactyly or clinodactyly polydactyly or clinodactyly. While Edward has overlapping fingers. It has overlapping fingers. Rocker bottom feet plus slash minus. Now rocker bottom feet can be seen in Patau, but a more characteristic symptom of Edward syndrome. As far as kidney is concerned, horse shoe kidney. Here the kidneys are almost normal or some other defect might be there, but horseshoe kidney is seen as far as Edward syndrome is concerned. Holoprosencephaly, not seen here, seen in Patau. I used to remember it saying that Patau has P in it. Anything that has P in it tends to be more Patau. Cleft palate, Patau. Holoprosencephaly, Patau. Polydactyly, Patau. P for puberty, 13. That's how I used to remember it. And these are the important differences. Rest, whatever is there is Edward syndrome. Rocker bottom feet, overlapping fingers, horseshoe kidney, like that. But P, you will be able to remember Patau. Holoprosencephaly. Alright. Polydactyly. Cleft palate. Alright. All these are there in Patau syndrome more. Alright. These are the important differences between Edward and Patau. Now let's see the important common points. Microphthalmia will be seen in both. Low IQ will be seen in both. Congenital heart disease will be seen in both. VSD is the most common one. And dysplastic ears will be seen in both. So these are the things where they won't ask questions on. Or if they give you, this won't help you in getting to the answer. But this table, very important table, will help you getting to the answer. Let's see the images now. Let's see the images now. Overlapping finger, Edward. All right. This is the rocker bottom feet, rocker bottom feet, rocker bottom feet, Edward. Edward. This is, can you see very clearly? Cleft palate and lip, patau, patau. Okay, so this is how you can understand the difference between Edward and patau. Now let's understand the differences between Turner and Noonan syndrome. Turner and Noonan syndrome. Now Turner syndrome occurs because of XO. It's an aneuploidy. It's a sex aneuploidy. Noonan syndrome occurs because of it's an autosomal dominant inheritance. It's an autosomal dominant disorder, and there are mutation in PTPN11 gene. PTPN11 gene mutations. There is PTPN11 gene mutation. Now, since it is autosomal dominant, Noonan can be seen in both males and females. It can be seen in both males and females. All right. Now, as far as phenotype is concerned, how they will look physically. Phenotype means physical appearance. Phenotype means physical appearance. This is same. This is exactly the same in both Turner and Noonan. This is the reason why sometimes Noonan is called as male Turner, but it is a misnomer. They are not the same. There are radically different disorders, but the appearance is same, which is the reason why a male who has appearance like a Turner is called as a male Turner. The phenotype is same. The physical appearance is same. And what is the physical appearance? What is the characteristic physical appearance? Remember 3 W's. Remember 3 W's. 3 W's. What are these 3 W's? You will have your webbed neck. You will have widely spaced nipple, and you have a wide carrying angle. You will have a wide carrying angle and short stature So short stature is common in both Noonan and Turner. Both will have webbed neck, both will have widely separated nipple, and both will have webbed angle. So the phenotypic appearance in both Noonan and Turner is exactly the same. Looking at them, you won't be able to say it is Turner or is it Noonan. But the genesis is very different. Turner occurs only in females. It is because of XO, one X chromosome is lost. In case of Noonan, it is an autosomal dominant inheritance in a PTPN11 gene mutation. Another important difference is between the cardiac abnormalities and the IQ abnormalities. Turner tends to have what? Turner tends to have bicuspid aortic valve and aortic coarctation. Bicuspid aortic valve. So aortic coarctation. Left side of the heart is affected. Left side of the heart is affected. While in Noonan syndrome, right side of the heart is affected. Right side is affected. So right side has what? Pulmonary artery. So there will be pulmonary artery stenosis. There will be pulmonary stenosis. There will be pulmonary stenosis as far as Noonan syndrome is concerned. In Noonan syndrome, the IQ is reduced while the IQ is normal as far as Turner syndrome is concerned. Another important difference. All right. So let's see the images. This is a Turner phenotype. This is an image of a Noonan syndrome. This is an image of a Noonan girl. If you actually, when I took the picture, when I saw the picture from where I took it on the internet, it's actually Noonan. But the phenotype will look exactly like Turner. That's why it's called as male Turner, because males may have the Turner phenotype and same physical appearance occurs. That's why it is called as Turner's phenotype. You can see the widely spaced nipples. You can see the webbed neck. And you can see the short stature as well. All right, this is a Turner's phenotype, which is common in both Turner syndrome and Noonan syndrome. But Noonan is an autosomal dominant seen in both males and females. Because of PTPN11 gene mutation, and the difference is pulmonary stenosis and the coarctation and the bicuspid aortic valve. This is the reason here you can make the answer very easily. Short stature, Turner phenotype. Undescended testes, male हो गया. तो टर्नर तो हो ही नहीं सकता. And pulmonary stenosis, and this is the reason why the answer here was Noonan syndrome. Answer here was Noonan syndrome. All right. Answer here was Noonan syndrome. Now let's discuss about the dehydration and pneumonia management, the IMNCI management of dehydration and pneumonia. Very important, asked multiple times. Let's discuss this. Which of the following is given to an irritable child with dehydration? Which of the following is given to an irritable child with dehydration? Tell me the answer. Correct. Answer is ORS. Now, let's see. A 17 kg child on dehydration correction. Calculate the maintenance fluid required in 24 hours. Calculate the maintenance fluid required in 24 hours. Calculate the maintenance fluid required in 24 hours. Tell me the answer to this question. What is the answer to this question? So 1700 ml is incorrect, IV fluids is incorrect, ORS is correct, 1700 is incorrect. If you're saying C for 27th question, 1350 ml, then that is correct. Here the answer is 1350 ml. Here the answer is 1350 ml. They're asking about maintenance fluid. They're asking about maintenance fluid in 24 hours. I'll talk about why you are answering 1700, why the 1700 that you are answering is incorrect. It's asking about maintenance fluid, which is calculated with the holiday cigar formula. They are not asking about the dehydration correction. They are not asking about dehydration correction. And there's a difference between the dehydration correction volume that you give and the maintenance fluid in 24 hours that you give. Okay, it is 1350 is the correct answer. Now let's see what is the next question, 28. Again, what is the management? What is the correct answer in this particular question? I've highlighted A, but I wanted to see if you will answer A also. A is not the answer actually. A is not the answer. I've already given a hint. For 28th, A is not the answer. IV fluid is not the correct answer. I'll tell the formula, Pooja. I'll just come up. I'll discuss everything about dehydration correction and everything. Don't worry. Kani Mozi was the first one to be correct. Now people are answering it correctly. ORS is the correct answer. Now let's discuss about dehydration correction a little bit. Now let's discuss about dehydration and dehydration correction. So first, as far as dehydration is concerned, you have to understand, you have to first classify. The first thing is that you have to do is classify whether the child is having no dehydration, some dehydration, or severe dehydration. Whether the child is having no dehydration, some dehydration, and severe dehydration. And how do you classify? you use these 4 parameters. These 4 parameters are given as far as IMNCI is concerned. These 4 parameters are given in IMNCI. There are 2 other parameters, tongue and tears, but they are not given in IMNCI. They are not given in IMNCI. Only these 4 parameters are given as far as IMNCI is concerned. All right. So these 2 parameters, we'll discuss about them, but we won't use them for classification as far as IMNCI is concerned. We'll use only the above 4 one as far as IMNCI is concerned. These 4 classes are used. So now as far as no dehydration is concerned, the general condition of the child, no dehydration, normal, alert and active, skin pinch goes back normally, thirst normal, eyes normal. Now when some dehydration occurs, when there is some dehydration, now the child has, there is no fluid in the, the child has basically lost some amount of fluid, there's some dehydration, right, because of diarrhea. Child wants water. So he will drink the water eagerly. He will eagerly drink the water. He'll be very thirsty. He'll be very thirsty. All right. General condition because he wants water. Pani do na, jaldi se pani do na. He'll be irritable. He'll be what? Irritable. He'll be irritable. And because the body has lost water, the skin pinch will go black slowly and the eyes will be slightly sunken. The eyes will be slightly sunken. That is as far as some dehydration is concerned. Now, what happens as far as severe dehydration is concerned? In severe dehydration, the body has lost so much water. The body has lost so much water that now the baby has become totally lethargic, ekdam lethargic ho gaya. He'll be like, no water, he's almost a moribund kind of a person. He'll be like, chhod do yaar, zindagi mein kuch nahi rakha. All right. Now what will happen? The baby is now in severe dehydration. He'll become comatose or lethargic. Comatose or lethargic. That now baby has become so comatose and lethargic, he won't be able to drink because he is lethargic and he is comatose. The skin pinch will go back very slowly. It will go back very slowly. And the eyes will be very sunken. The eyes will be very sunken. So understood the difference between some and severe dehydration? Some, the body has lost water. The baby wants that water. So he'll be irritable. Do na, jaldi se pani do na mere ko. I'll be very thirsty to drink the water. And in severe dehydration, he'll be totally moribund, totally comatose. He'll be like, kya karu main? Ekdam. So he'll be comatose. He will be comatose. He will be lethargic. And he'll be unable to drink. His comatose is lethargic, so how will he be able to drink water? Right? This is the reason in severe dehydration, and the skin pinch will go back very slowly, and the eyes will be very, very sunken. Eyes will be very, very sunken. So this is the difference between some dehydration and severe dehydration. And in no dehydration, obviously everything is going to be normal. If 2 out of these 4 is there as far as some dehydration is then we'll call it as some dehydration. Of some is present, and if 2 out of 4 of severe is there, then we'll call it as severe dehydration. So 2 should be there, not 1, 2 should be there. Not 1, 2 should be there. All right. So severe dehydration. 2 out of the 4 should be there. 2 out of the 4, not 1, 2 out of the 4 should be there. So if this and this is there, severe. Even if the skin pinch is slow, even if the eyes are only sunken, they're not very sunken, but the child is comatose and unable to drink, severe. 2 out of 4 is there, severe. 2 out of 4 of some is there, some. Okay. Now let's discuss about the management. Now let's discuss about the management. The reason I haven't told you this tongue and tears is because they are not part of IMNCI, so it's better not to. But simple hai. Tongue mein bhi kya hoga? Some mein they'll be dry and it will be very dry. Tears won't be there in some and severe. So again, it's not a part of IMNCI, so better not to consider it. Better not to consider it. Remember these are the 4 more important ones, and they will be there in your question as well. All right. Now let's see the management. In no dehydration, what are you going to do? You're just going to give ORS. You're just going to give ORS. How much? 5 to 10 ml per kg with every loose stool. All right. So whenever there is a loose stool, he'll lose some water. You replace that much amount of water with 5 to 10 ml per kg of ORS. That is as far as no dehydration is concerned. Nothing extra has to be done. No rehydration has to be done. In some dehydration, again you have to use only ORS only. ORS only has to be used. You don't use IV fluids. It's some dehydration, ORS has to be used. Child is able to drink, so give ORS. But now you have to rehydrate the child. Now you have to rehydrate the child, and you do this rehydration with how much amount of water, how much amount of ORS, sorry, 75 ml per kg of ORS, and this is given over 4 hours, and this can be given orally if the child is taking orally. In case the child is not able to take orally, it can be given via NG. But remember, there is no IV fluids. There is no IV fluids. In some dehydration, there is no requirement of IV fluids. Only ORS, 75 ml per kg of ORS, 75 ml per kg of ORS given over 4 hours. Given over 4 hours. How much? 75 ml per kg of ORS given over 4 hours. Can be given not IV, either oral or via NG. This is to rehydrate. Plus, important plus, anytime the child has loose stool, you again replace that amount much loose stool. Plus 5 to 10 ml. This is only for rehydration. अब कोई extra loose stool होगी तो उसको replace तो करेंगे. Plus 5 to 10 ml per kg with of each of ORS with each loose stool. This is as far as some dehydration is concerned. As far as severe dehydration is concerned, now the child is moribund. I said the child is comatose, I said the child is lethargic and unable to drink. If is not able to drink, then obviously now you have to use what? You have to use IV fluids. And how much IV fluids? And which IV fluid? So preferred IV fluid is RL with 5% dextrose or RL. These are the two preferred IV fluids, and this has to be given at 100 ml per kg. This 100 ml, this is for the rehydration part. How much do you have to give? You have to give 100 ml per kg. And this 100 ml per kg, if the child is less than 1 year old, is given over 6 hours. The child is more than 1 year. It is given over 3 hours. In the 6 hours also, the first 30 ml per kg, is given over 1 hour. The rest 70 ml per kg is given over 5 hours. And in this also, the first 30 ml per kg, 30 plus 70 is 100. This 100 is divided. The first 30 ml is given over 1 hour. The rest 70 is given over 5 hours in child less than 1 year. Here also the first 30 ml per kg is given over half hour. And the rest 70 ml per kg, is given over 2.5 hours. But remember, this is for rehydration. The question had asked about maintenance fluid. The question that we discussed, which you all got wrong, asked about maintenance fluid. Maintenance fluid is what you require to maintain your body. This is a fluid which is required irrespective whether you are having dehydration or not. तो इसको सबको चाहिए, मुझे भी चाहिए, तुमको भी चाहिए, you also require it, I also require it. Alright, everyone requires it. This is the maintenance fluid which is required in obviously in 24 hours. This is given by the formula holiday cigar formula. Alright, and holiday cigar formula says for the first 10 kg, it is 100 ml per kg for the first 10 kg over 24 hours. For the next 10 kg, depending upon the weight of the individual, next 10 kg, that is between 10 to 20 kg, it is 50 ml per kg, again over 24 hours. And for the next kilograms, that is beyond 20 kg, for every kilogram, it is 20 ml per kg. Alright, these are the, remember, this is the maintenance fluid. Everyone requires it. This is not the dehydration correction or the rehydration. Rehydration is this. Severe rehydration is this. This is rehydration. This is maintenance. Difference. Now let's revisit the question. Alright. The question had asked The question had asked 17 kg child on dehydration correction, sure. But the question hadn't asked about rehydration. You're right, 1700 ml wala part sahi tha. But question had asked maintenance fluid in the 24 hours. Even if we were doing, the first pointer that it is not asking about rehydration is 24 hour was given. Rehydration and severe dehydration correction is given over how much time? Either 6 hours or 3 hours, right? Either 6 or 3 hours. Here they're asking in 24 hours and they're asking what? They're asking maintenance fluid. So holiday cigar, let's apply the holiday cigar formula. First 10 kg, 10 into 1000, 10 into 100, sorry. So 1000 ml in 24 hours. Next 7 kg, because the child is 17 kg. Child is what? 50 into 7 is equal to 350 ml in 24 hours. So together it will be 1350 ml in 24 hours. So answer C. Answer is going to be C. Understood the difference? Understood the difference? All right. So the question was asking not the rehydration. The question was asking calculate the maintenance fluid, and it had given you a clue also in 24 hours. Let's say the question was not asking this. Let's say the question was not asking this. The question was asking rehydration. The question was asking, they said there is severe dehydration, now calculate the rehydration. Then you were correct. Then it would be 17 into 100 is equal to 1700 ml. But remember, the time period would have been either 6 hours or 3 hours. Either 6 hours or 3 hours. That is the rehydration correction. They were here asking about maintenance. So see the question carefully. See the question carefully. Now let's see the other questions as well. What is given to an irritable child with dehydration? What is given to an irritable child with dehydration? Irritable, some dehydration, hai na? They are already saying there is dehydration. So it is not no dehydration, okay? So some dehydration, and irritable also is seen in some dehydration. So in some dehydration we give ORS. Now let's look at this question. 18 episodes. Child is irritable but eager to drink. 2 out of 4 of some dehydration. 2 out of 4 of some dehydration. And in some dehydration we give what? In some dehydration we give ORS. So again answer is going to be ORS, not IV fluids, not IV fluids. Because irritability and eagerness to drink are some dehydration, not in severe dehydration. Alright, so understood everything? Understood everything? Alright, understood everything? Understood the dehydration management? I'll summarize it once. I'll summarize it once. I'll summarize it once. Fluid amount time. Okay. ORS, IV fluid, RL with 5% dextrose. Amount 5 to 10 ml per kg with each loose tool. There's no, you're not rehydrating. There is no rehydration only. Here it is 75 ml per kg ORS over 4 hours. Over 4 hours. Here it is 100 ml per kg over 3 hours or 6 hours. If less than 1 year, if more than 1 year. Okay, summarized. All right. Summarized. All right. This is for rehydration. This is for rehydration. If they ask maintenance, then use which formula? Then use holiday cigar formula. Then use holiday cigar formula. So percentage of weight loss, yeah, they actually haven't asked any time, but I will tell you since you specifically asked. Less than 5%, 5 to 10%, more than 10%. Since you asked this, I'm writing it down, but they actually haven't asked it. If you actually look at the FMG papers, NEET PG mein, yes, they have asked this once, but FMG mein, if I remember correctly, they haven't asked. All right, no dehydration, the weight loss is less than 5%, some is 5 to 10, and severe is more than 10%. You want to keep it in the table, you can, but not something that is important. This part, understood? And understood ki maintenance ke liye, maintenance is done over 24 hours, and for that we use a different formula, that is the holiday cigar formula. That is the holiday sick hour formula. So I was talking about Sana, I was talking about dehydration correction, the fluid one. Obviously, अगर diarrhea की management पे आते हो, if you come to diarrhea management, then all these children need to be given zinc. All of them need to be given zinc at 20 mg per day for 14 days. For 14 days. I know this. I know that all of you already know this. That's why I was not talking about it. I know in this you were getting confused. That's why I specifically taught about this. All right. ये correction वरेक्शन लोगों को याद नहीं रहता, confused हो जाते हैं. That's why I specifically talked about this. That's why I specifically talked about this. All right. You're right. All the cases in no dehydration, some dehydration, severe dehydration, all of them are at least having diarrhea. You need to give zinc at 20 mg per day for 14 days. You need to give that to everyone. You need to give it to everyone. All right. Now let's discuss pneumonia. Now let's discuss pneumonia as per the new IMNCI guidelines. As per the new guidelines. Dextrose is RL plus 5% dextrose is what we give. RL with 5% dextrose. I'm not understanding what you're asking between division between RL and dextrose. RL with 5% dextrose, not and उसका कोई division होता है. 100 ml RL में 5 ग्राम per deciliter के हिसाब से 5% dextrose होगा. RL with 5% dextrose. I hope you understood that. There is no division कि पहले RL देना है बाद में dextrose देना है. ऐसा कुछ नहीं है. RL with 5% dextrose together is the fluid of choice. If RL with 5% dextrose is not there, then simple RL can also be used. I've written there. I've written here. Or simple RL can also be used. All right. So 11 ka everyone is writing correct. Answer is D. Pneumonia, oral amoxicillin follow-up. So you understood the difference. Actually, this was the main cheese that I wanted to ask about. And what is the answer to this question? Option number 12 also. This is also option D only. Both of them have option D as the correct answer. All right. So let's discuss the pneumonia management as far as the IMNCI is concerned. Let's discuss the pneumonia management as far as the IMNCI is concerned. So IMNCI says that depending upon the condition of the child, there can be 3 categories. Again, you can classify it into 3 main categories. The first category is only cough and cold. Only cough and cold. Okay. The second category is pneumonia. The second category is pneumonia. And the third category is severe pneumonia or very severe disease. Okay, as far as cough and cold is concerned, there is no requirement of any antibiotics. You don't require any antibiotics. Just give soothing measures. Do what? Give soothing measures. All right, you can consider giving salbutamol syrup if there is wheezing. All right, so this is as far as cough and cold is concerned. If pneumonia is there, what do? You give oral amoxicillin. You give oral amoxicillin and you follow up for 5 days. You give oral amoxicillin and then you follow up. If there is severe pneumonia, then you do what? You give the first dose of IV antibiotic, which can be gentamicin, which is usually gentamicin, and then you refer. You give the first dose of IV antibiotic can be gentamicin, some people give amoxicillin, but basically first dose of IV antibiotic and then you refer. Okay. Now, what is the difference between pneumonia and severe pneumonia? What is the difference between pneumonia and severe pneumonia? Let's see this. Let's see the difference between pneumonia. So pneumonia is when there is fast breathing. When there is fast breathing, how do we say when there is fast breathing? Depending upon the respiratory rate. In less than 2 months, if the respiratory rate is more than 60, you will call it as fast breathing. In 2 months to 1 year, if it is more than 50, you will call it as fast breathing. In more than 1 year, if it is more than 40, this is obviously per minute, or there is chest indrawing, This is very important because chest indrawing earlier was considered a part of severe pneumonia, but now chest indrawing is considered a part of only pneumonia. Very important difference, very important thing I want you to understand. Just chest indrawing nowadays is considered a part of pneumonia. In earlier days, it was considered a part of severe pneumonia. Current guidelines say chest indrawing को सिर्फ pneumonia मानो. अगर सिर्फ pneumonia मानोगे तो क्या करोगे? सिर्फ oral amoxicillin दोगे 5 दिन के लिए. सिर्फ oral amoxicillin दोगे 5 दिन के लिए. All right. Now, as far as severe pneumonia is concerned, this is when there is stridor in a calm child. When there is stridor in a calm child, or there is high grade fever, SpO2 less than 92%, there is seizures, there is lethargy or dull child. If there are any signs of severe disease, anything is there, then you will call it as severe pneumonia. Then you will call it as severe pneumonia or very severe disease. You will call it as severe pneumonia or very severe disease. All right. So very important to understand that chest indrawing nowadays has become a part of pneumonia. Now let's see these two questions. Let's see these two questions that we discussed. Child is coming to you with complaints of cough. Respiratory rate is 38 per minute. How old is the child? 20. So respiratory rate is less than 40. So it won't be fast breathing. But chest indrawing is there. So this will be what? This will be only pneumonia. What will you do as far as pneumonia is concerned? You will give pneumonia, oral amox and follow-ups. On option D is correct. In pneumonia, you don't give IV antibiotics. Option A is incorrect. This is not severe pneumonia. All right. And I said if wheezing has to be there, then you can consider oral syrup. But again, this is not asthma, so there is no steroids and oxygen. Fair enough. In this child, this is a 5-month-old child. 5-month-old child with respirator of more than 50, it's 58. So first thing is it's more than 50, so pneumonia to definitely hai. But along with pneumonia, there is high-grade fever and lethargy. So this is severe pneumonia. Severe pneumonia is obviously antibiotic first dose and refer. All right. Antibiotic first dose and refer. And with this we can complete the pneumonia management. Now let's discuss about last thing I'm going to discuss are important congenital heart diseases, cyanotic congenital heart diseases. Important cyanotic congenital heart diseases. All right. What can you see? The following condition has. Tell me the answer. Shubham, any danger sign is there, you will call it as severe pneumonia. Any danger sign is there, you will call it as severe pneumonia. एक भी होगा ना, lethargy भी होगी ना सिर्फ, वो severe pneumonia हो जाएगा. So people are answering it correctly. It is decreased pulmonary blood flow. Because you can see very clearly what is there. This is a boot-shaped heart. This is a boot-shaped heart, which is seen in what? Which is seen in tetralogy of Fallot. Tetralogy of Fallot. All right. Now, what are the 4 components of tetralogy of Fallots? So there was only one component that you really need to remember, and I always talk about this in all my videos, that we tend to memorize 4 components of tetralogy of Fallot when you just need to understand one thing. Imagine this is the heart. Imagine this is the heart. This is the right atrium. This is the right ventricle. This is the left atrium, and this is the left ventricle. And here is coming out your pulmonary artery. Here is coming out your pulmonary artery. All right. All right. Here is coming out your pulmonary artery. Now in TOF, the main pathology, the main thing that happens is pulmonary stenosis. The main thing that happens is pulmonary stenosis. There is going to be what? There is infundibular stenosis or pulmonary stenosis. The main problem is pulmonary stenosis. Now, what will happen because of pulmonary stenosis? The blood won't be able to go into the pulmonary artery. The blood won't be able to go into pulmonary artery. If it is not going to pulmonary artery, it won't reach the lungs. There is going to be decreased pulmonary blood flow. There is going to be decreased pulmonary blood flow. It's going to be decreased pulmonary blood flow. Second thing, what will happen? The right ventricle obviously will try to pump the blood. So there's going to be right ventricular hypertrophy. There is going to be right ventricular hypertrophy. So first thing is that there is infundibular stenosis. The first thing is that there is infundibular stenosis. Second, in order to push the blood into the pulmonary artery, there is going to be right ventricular hypertrophy. But the blood won't be able to grow. The blood will instead reach left ventricle through a what? It will reach a left ventricle through a ventricular septal defect. It will reach the left ventricle through a ventricular septal defect of VSD. And the fourth component, because there is a ventricular septal defect, the aorta will appear that is overriding. So there will be a overriding of aorta. So remember, everything starts from pulmonary stenosis. Everything starts from pulmonary stenosis. Pulmonary stenosis will lead to right ventricular hypertrophy. Now right ventricle will try to pump the blood. It won't go into pulmonary artery because there is stenosis. The blood will go through ventricular septal defect, resulting in a right to left shunt. And because there is a huge VSD, the aorta will look like it is overriding and causing a overriding aorta. So this is the reason. Never ever say RVH as the first component of TOF. Always remember it in this sequence. First, there is pulmonary stenosis. There is infundibular stenosis. Subpulmonary. The stenosis is below the pulmonary wall, so that's why it's called as subpulmonary stenosis. It is called as subpulmonary stenosis. Why? Because it is below the level of the valve. This pulmonary stenosis will lead to what? Right ventricular hypertrophy. Now the right ventricle wants to pump the blood will go to the left side with the VSD. And because there is a VSD, the aorta will look like it is arising from the top, causing overriding aorta. So remember, in this sequence, the primary pathology is a pulmonary stenosis. Because there is pulmonary stenosis, there is right ventricular hypertrophy. Because there is right ventricular hypertrophy, blood will go from the VSD from the right to left, resulting in the right to left shunt, and then causing an overriding aorta. So these are the four components of tetralogy of Fallot. Exactly, very important. Not a valvular stenosis. It is subpulmonary stenosis. It is below the valve. It is not valvular stenosis. It is subpulmonary stenosis. Very important to remember. Excellent, who has said this? Right, Manish, absolutely. It is subpulmonary stenosis. It is infundibular stenosis. It is infundibular stenosis. All right. Now let's see important. So this is boot-shaped heart. This is seen in what? Tetralogy of Fallot. This is what is referred to as egg on string. This will be seen in where? Tell me the answer very fast. Tell me, where is this egg on sign appearance seen? Egg on string appearance seen? Tap PVC is wrong. No, not tap PVC. TGA is correct. This is seen in transposition of great arteries. And अब थोड़ा सा correlate करना शुरू कर दो. Transposition of great arteries was the most स्पेसिफिक साइन ऑफ इन्फेंट और डायबिटिक मदर। ऐसे ना, ऐसे रखते रहोगे ना तो चीजें बहुत सारी, लगता बहुत सारा सिलेबस है, वो करके ना छोटू सा हो जाता है। यहां पे लिख लो हल्का सा, आईडीएम मोस्ट स्पेसिफिक, है ना? वेरी गुड। नाउ टेल मी what is this? This is a box shaped, can you see? This is a box shaped heart. This is seen in where? This is seen in Epstein anomaly. This is seen in Epstein anomaly. All right. Epstein anomaly has box shaped heart. It has Himalayan P wave. It has Himalayan P waves. The P waves are going to be very, very huge. Something like this. This is going to be the P wave. It has Himalayan P wave. All right, very important. Two important things about Epstein anomaly. And Epstein anomaly is caused due to which? Let's correlate with pharma. Epstein anomaly is caused due to taking which drug? It is caused due to lithium intake. It is caused due to lithium intake. It is caused due to lithium intake. Okay. And last, can you see this is looking like a snowman? This is looking like a snowman. This is seen as far as TAP PVC is concerned. TAP PVC has snowman sign, or you can say that this is 8 also. So TAP PVC has figure of 8 or snowman sign. TAP PVC has figure of 8 or snowman sign. All right. So with this, we basically complete most of the important topics as far as pediatrics are concerned. Someone asks, sir, मैं कितने question expect कर सकता हूँ? I will say 60 to 70% expect कर सकते हो। इसमें बस 60-70 के लिए एक कैवेट है, एक वो NRP जरूर पढ़ लेना। मैंने टॉपिक्स बता दिए तुम्हें, एक NRP जरूर पढ़ लेना। ओके, एक NRP डेफिनेटली पढ़ लेना। ओके, एक ना जल्दी से मैंने थोड़ी बहुत इमेजेस रखी हुई हैं, ये जल्दी से मेरे को बस इनके आंसर्स बताते रहो और एकदम रैपिड फायर करेंगे, 5 मिनट में खत्म करेंगे इसको, ठीक है? 5 मिनट में खत्म करेंगे। Okay, so these are what are the neural tube defects. These are the caudal neural tube defects. नीचे हो रहे हैं. There can be cranial neural tube defects also. Example is anencefali. An example is anencefali, which is not compatible with life. All right. The caudal neural tube defects include your spina bifida. And the spina bifida itself is of two types, spina bifida occulta or spina bifida cystica Occulta mein there is only a vertebral defect. Vertebra defect. So it is occult. It is not visible. Because it is covered with skin. The skin will have a dimple. There will be a dimple or a tuft of hair on the skin, but otherwise it is not visible. There won't be any deficit. In meningocele, which is a part of spina bifida cystica, there is only meninges. But in myelomeningocele, what is going to be there? There is going to be nerves also. There is going to be nerves plus meninges. So in myelomeningoceles, you will see deficits. But in meningoceles, you won't see any deficits. Meningocele, because it is filled with cyst, with meninges and meningeal fluid, CSF, it will be trans-evaluation test positive. TL positive. All right. What is the drug which is given for prevention? Folic acid. What is the dose? It is given periconceptionally. 1 month prior to conception, you have to start it. What is the dose? 0.4 mg or 400 microgram. If mother earlier had a baby with neural tube defects, then the dose is 10x. If the mother earlier had a baby with neural tube defect, the dose is 10x, then it becomes 4 mg. All right, then it becomes 4-MZ. Drugs which can cause neural tube defects, these include the anti-epileptic, particularly your valproate and phenytoin. That is your anti-epileptic drugs. This is a photo of a baby who's suffering from congenital hypothyroidism. You can see what? You can see protruding tongue. All right, you can see the protruding tongue, you can see coarse facies. All right, and in congenital as far as congenital hypothyroidism, we do what? For screening we do. What do we do for screening? We use a TSH based screening. If the umbilical cord TSH is less than 20, it is normal. If it is more than 20, it is abnormal. Congenital hypothyroidism, we use a TSH based screening for all children. Umbilical cord TSH or heel prick TSH can be used. Heel prick can also be considered. Less than 20 normal, more than 20 abnormal. This is what? This is the pseudomembrane. This is the pseudomembrane seen in diphtheria. Diphtheria toxin inhibits what? Diphtheria toxin inhibits elongation factor 2. Main complication is what? Myocarditis. Heart problems. And vaccine is what? DPT. Okay. This is what? This is tetanus. This is what? This is tetanus. You can see the opisthotonus. What is the vaccine? Again, DPT. DPT is a vaccine. But remember, beyond 7 years of age, we do not give DPT. We do not give DPT. We give what? We give lower dose of diphtheria. We give acellular pertussis. And we give normal toxide. So, DTaP is given. Beyond 7 years, DTaP is given. All right. Then this is what? This is Harpenden caliper. Used to measure skin fold thickness. Which is also age-independent growth parameter. The other age-independent growth parameter was mid-upper arm circumference. I already talked about. So skin fold thickness is the age-independent parameter. Most common site is triceps. Most common site used is triceps. You can see this is a triceps. This is the most common site. All right. More than 10 centimeter is normal. Less than 6 centimeter is considered abnormal. Okay. More than 10 is normal. What is this? And where is it seen? This is seen in juvenile dermatomyositis. JDM. All right. Right. Cotton's papules. This is what? This is strawberry tongue. Seen where? In Kawasaki disease. What is required for diagnosis of Kawasaki disease? What are the criteria? So fever plus 4 of the following. Conjunctival conjunctivitis, bilateral cervical adenopathy, more than 1.5 centimeter. Oral mucosa changes, which basically is your strawberry tongues. Then extremity changes. Which basically includes your periungual, edema. The 5th point is, you're absolutely right, rash. desquamative rash. So this is the diagnosis. What is seen here? What is this? This is what is referred to as a faggot cell. This is what is referred to as a faggot cell. This is a faggot cell. You can see multiple OR rods. You can see multiple OR rods here at one point, collected at one place. Faggot cells are seen in APML. APML has which translocation? Translocation 1517. APML has which translocation? Translocation 1517. What do? What do we give? ATRA plus ATO. We give ATRA plus ATO. And this ATRA plus ATO can result in a syndrome called differentiation syndrome. Can result in differentiation syndrome. And the treatment of differentiation syndrome is dexamethasone. It is dexamethasone or steroids. All right. ATRA plus ATO will differentiate the promyelocytes. Those promyelocytes, when differentiated, will cause what? Differentiation syndrome. Differentiation syndrome has weight gain, fever, things like that. For treatment for differentiation syndrome, we'll give DEXA. Okay. This is what? This is AML. This is normal AML. Normal AML, not APML. This is normal AML. This is normal AML. Can you see the OR rod? Can you see OR rod? Can you see multiple nucleoli? All right, so OR rod, multiple nucleoli. So this is a myeloblast. This is a myeloblast. All right, myeloblast. Now, I'm not going to go into the too much details, but just let's point it out. M2 is associated with chloroma. M5 is gum hypertrophy. And M7 is acute megakaryoblast leukemia, AMKL, which is seen, which is the most common in Down syndrome, most common AML subtype in Down syndrome. All right. What is this? These are Reed-Steinberg cells. Auli. Seen where? Seen in Hodgkin lymphoma. Seen where? Hodgkin. Hodgkin is of two types, classical and nodular lymphocyte predominant Hodgkin lymphoma. Classical is CD1530 positive. This is CD20 positive. All right. CD1530 positive. All right. What is this? This is IHPS, infantile hypertrophic pyloric stenosis. You can see what? You can see string sign. You can see mushroom sign. They present with vomiting in first week of life. Vomiting is what? Non-bilious. And characteristic abnormality that is seen is metabolic alkalosis with paradoxical aciduria. This is what? This is Hirschsprung disease. You can see that dilation, there is dilation of proximal segment. And contraction of affected segment. This is Hirschsprung. This is Hirschsprung disease. Why does it occur? Failure of migration of neural crystals. Why does it occur? Because of failure of neural crest cell migration. And this will result in what? Constipation, obstipation, obstructions, things like that. All right. What is this? This is omega shaped epiglottis. Seen where? Laryngomalacia. Laryngomalacia. What is this? You can see this very clearly. This is the characteristic slabbed cheek appearance. So the slap cheek appearance is caused by parvovirus B19, which causes what is referred to as erythema infectiosum. Erythema infectiosum, which is also known as the fifth disease. And we all know parvovirus B19 can also cause, it can cause non-erosive arthritis, and it can cause hydrops fetalis, and very characteristically it can cause aplastic crisis. It can cause aplastic crisis. This is what? This is measles. This is what? This is measles. This is a typical measles rash. For prevention, we give what? We give MMR or MR, all right, at 9 months and 18 months. In case of an epidemic, can be given at 6 months also. In case of epidemic, it can be given at 6 months also. It's a live vaccine. It's a live vaccine, so it is contraindicated in immunodeficiency. It's a live vaccine, so it's contraindicated in immunodeficiency. This is what? This is how mumps looks like. You can see parotitis. You can see parotid enlargement. You can see the parotid enlargement and complication. Common complication is orchitis. Common complication is orchitis. This is what? This is an example of, this is a child with Prader-Willi syndrome. Paternal genomic imprinting, 15q11. Hyperphagia. They eat a lot. That is the reason for obesity. Okay. There is hypogonadism and hypotonia and low IQ. This is as far as Prader-Willi syndrome. Versus, I've not taken the picture. You have your Angelman syndrome. That is also 15q11, but that is maternal. Angelman. P for Prader-Willi, P for paternal or papa. Angelman has M in it, so maternal imprinting. They are what are referred to as happy puppets. They are happy puppets. So they will happy puppets. Why? Because they have ataxia, and at the same point of time they have inappropriate laughter. They have ataxia, they have inappropriate laughter, and they also have low IQ. They also have low IQ. That is your Angelman syndrome. With this, we complete the entire pediatrics. I've done the entire revision for most of the things. अच्छा हाँ sorry मैं उल्टा बोल दिया just 1 second. What I basically mean to say is the maternal gene is imprinted and paternal gene is also imprinted, or basically it is deleted. I wrote imprinted, paternal gene is deleted, maternal gene is imprinted. Maternal gene is imprinted. Sorry. थोड़ा जल्दी बोल रहा था तो small mistake. I'm so sorry for my, like, you know, you're absolutely right. In Prader-Willi syndrome, maternal gene is imprinted, the paternal gene is deleted, and herein there is paternal imprinting and the maternal gene is deleted. I'm so sorry, you're absolutely right. Jaldi mein I think ulta bol diya maine, but absolutely right. Prader-Willi syndrome, maternal gene is imprinted, so it won't be expressed, and paternal gene is deleted, so there won't be any expression of the gene, resulting in Prader-Willi syndrome. As far as Angelman syndrome is there, maternal gene is deleted, paternal gene is imprinted, so that paternal gene won't be expressed. It will be happy puppets. You're right. Kisne bataya tha? Absolutely right. Pooja was said it correctly. You're absolutely right. The normal maternal gene is imprinted. This gene is normally maternal imprinted. So paternal gene is now getting deleted. So no gene expression is there of that particular disorder. All right. So this is as far as Prader-Willi syndrome is concerned. All right. So with this, we complete the particular topic. We complete the entire topic of, we complete entire pediatrics, and यार कोई mnemonic नहीं है. Last 10 day के लिए मैं simply ये तो मैं बोलने वाला हूँ as far as केदार, yes यार, I was wrong, मैंने बता दिया, I'm so sorry, कभी कभी गलती हो जाती है, कुछ ऐसा नहीं है. I was just trying to complete everything sort of fast. So in 3 hours, I can tell that at least 60 to 70% questions are going to come from this for pediatrics. In this 3 hours that you have revised, 3.5 hours that you have revised, 60 to 70% are definitely fully, possible 100% questions might come from this also. But if that happens, great. But as far as the last 10-day plan is concerned, what I will simply say is that see the important subjects first, कि किसकी relative weightage कितनी है, and most importantly जो high weightage subjects हैं and volatile subjects हैं उनको last के 3-4 दिन में करना. For example, subjects like I would say biochemistry, or subjects like microbiology, or subjects like these subjects, they are not small weightage, they're decent weightage, and they're very volatile also. Pharmacology, try to do them towards the exam. And subjects which you are more confident in, for example, medicine is, most people, you are usually confident in medicine. बहुत बार पढ़ ली होती है, path भी पढ़ी होती है, pharma भी पढ़ी होती है, medicine you are usually confident in. Try to do them towards day 9 or day 10. Okay, in fact, what we used to say in our last 10-day revision is, even if you don't do medicine, it's perfectly fine. Ensure that path pharma is done properly, because if path pharma micro is done properly, you don't need to revise medicine. You really don't need to revise medicine. All right. So if your path pharma, focus on, very important thing I would say, for the last 10 days, focus on P. Focus on P. All right, for the last 10 days, focus on the P's. What are the P's? ऑलराइट, ये 4 सब्जेक्ट तो रिवाइज करके जाने ही हैं. ये 4 सब्जेक्ट तो रिवाइज करके जाने ही हैं. पैथ, फार्मा, फिजियो एंड पीडियाट्रिक्स, ये तो रिवाइज करके जाने ही हैं. प्लस मैं एक और पी ऐड कर दूंगा, पीएसएम. सॉरी, एक पी मैं भूल गया, पीएसएम. ये तो रिवाइज करके जाने ही हैं. मतलब और कुछ हो ना हो, ये 5 रिवाइज भी कर लोगे, इवन देन आई एम टेलिंग यू, यू विल रीच 100. मतलब ये 5 सब्जेक्ट से ही 100 को निकल जाओगे, 100 प्लस हो जाओगे, है ना. और बाकी बेसल नॉलेज से तुम लोग तुक्के भी मार दोगे ना, तो बाकी 200 क्वेश्चंस में इवन इफ यू गेट 1/4 करेक्ट, सिंपली बाय द लॉ ऑफ प्रोबेबिलिटी, विल गेट 150. मनीष, मेरे को एक पर्सनली मैसेज कर देना ऑन इंस्टाग्राम, आई विल टॉक टू यू. ठीक है, चलो, आई विल टेक योर लीव नाउ. That's more than enough. Thank you. Grateful for everyone who gave me the opportunity. Grateful if you enjoyed this particular session. And you guys will rock. You guys will shock, and you guys will pass. All the best. Eid Mubarak, and